انا ماشي بس انا بدي اكبر فرصه للناس عشان تدخل تستفيد من المحاضره وبيدخلوا دلوقتي كتير. السلام عليكم ورحمة الله وبركاته. نرحب بجميع الحاضرين معنا وبأستاذنا دكتور أحمد البليدي، وإن شاء الله نكمل على خير اليوم الثاني من المؤتمر السنوي الخامس لطب الأطفال وحديثي الولادة المقام عبر زوم من خلال مستشفى السعود الألماني بالرياض. Our first speaker today will be our Professor Dr. Ahmed Al-Belidi, ex-head of Department of Pediatric Department, Cairo University. Dr. Ahmed is one of the pioneers of the pediatric medicine in Egypt and in Arab world, and he is an eminent speaker on Egypt and all Arab countries. Dr. Ahmed will give us a lecture about acute bacterial rhinosinusitis in children. اهلا بيك دكتور احمد وشرفتنا ونتشرف بسعادتك دايما.
اهلا دكتور نبيل.
شكرين على وجودك معنا.
الله يحفظك. اهلا بيك. السلام عليكم جميعا. It's always a pleasure to be with my dear Dr. Nabil and the SG Hospital, all the staff and all the doctors who are seeing this in Saudi Arabia. My talk today about acute bacterial rhinosinusitis in children. We will pass through these points briefly about the paranasal sinuses, the case definition, the microbiology, the predisposing factors, complications, and management. We have 4 sinuses, as you all know. You can see the frontal sinuses, the ethmoid, the maxillary sinus, and the sphenoid sinus. How early can these sinuses develop, and hence how early can the paranasal sinuses get inflamed? That's the age of development of the different sinuses. The maxillary and ethmoid sinuses appear by the 3rd and 4th month of gestation, so they can get inflamed in infancy, while the frontal sinus appear by the age of 6 to 8 years, so it will not be inflamed before the age of 6 years. The sphenoid sinus get pneumatized by the age of 5 years, and it can be inflamed from the age of 3 to 5 years, so this is just a reminder. The 2 in the middle, the ethmoid and the maxillary, can be inflamed from infancy. The lower one, which is the sphenoid, from 3 to 5 years, and the frontal sinus from 6 to 10 years. You can diagnose sinusitis, particularly maxillary sinusitis, as early as infancy. How we define sinusitis, whether it's acute or subacute? If the symptoms persist up to 4 weeks, this is acute. The symptoms from 4 weeks to 12 weeks, that's subacute. If the symptoms persist more than 12 weeks, that's chronic. What's recurrent acute sinusitis? When we have at least 4 episodes of acute sinusitis per year. Each episode lasts at least 7 to 10 days, but the patient should be symptom-free in between these episodes, because if he is not symptom-free, then it will be chronic rather than recurrent acute sinusitis. What's the incidence? The exact incidence is unclear, but we know that on the average, children have around 7 upper respiratory tract infections per year. 5 to 13% of them get complicated with bacterial sinusitis. So it has been estimated that almost 6 to 7% of children going for respiratory symptoms has an illness that goes with the definition of the acute bacterial sinusitis. However, we must know that the paranasal sinuses are almost always involved in the simple viral rhinosinusitis. If somebody have common cold, the sinuses are involved, but we do not call this sinusitis, although the sinuses are involved. And when we have sinusitis, usually the inflammation does not involve the nose and the purulent discharge that you are seeing from the nose, simply because the nose acts as a conduit for secretions coming from the sinuses. So if you look to the upper respiratory tract infection, the uncomplicated, the viral uncomplicated, you will find fever almost disappear by day 3. So the child may have fever or may not have fever, but almost disappear by day 3. While respiratory symptoms, the ones that we will mention, tend to disappear by 10, 11, maximum 12 days. So a question, how can I tell if the child has bacterial sinusitis or simply a common cold? Most of the colds, in fact, all of the colds should disappear or improve by day 10. The runny nose can become cloudy discharge, can become colored discharge, but it will disappear and improve by day 10. Some colds may have fever for 1 or 2 days, as I said. But I want you to remember 3 words, persistent, severe, or worsening symptoms. What do we mean by persistence? Because the sinusitis will be diagnosed according to this. If we have a runny nose of any quality with daytime cough, which may be worse at night, that persists for at least 10 days without improvement, that's called persistent. That's the form of sinusitis where we label it persistent. If the patient had fever of 39 degrees Celsius plus that lasts for at least 30 days, plus purulent, thick colored mucus, that's from the nose, that's called the severe type, severe sinusitis. What's the worsening? The patient will start with the cold that will improve by day 10 or earlier, and then he starts worsening either by re-onset of fever or by re-onset of daytime cough and runny nose. That's called double sickening. So I want you to remember that usually there is common cold. If symptoms persist or became severe or worsening, then we can diagnose sinusitis. And these are the clinical picture and the symptoms, mainly runny nose and daytime cough, also nasal obstruction. Nasal congestion means nasal obstruction. They may have low-grade fever and may have otitis media as well. And of course, there is irritability and headache. Severe infection will have not only purulent discharge from the nose, but high fever and sometimes edema around the orbit. What about the microbiology of sinusitis? It's the same of otitis media. In fact, we draw the microbiology of sinusitis from otitis media simply because it's easier to do tympanocentesis than to do sinus aspirate. So you will find the 3 organisms, the strep pneumoniae, the Haemophilus influenza, and the Moraxella catarrhalis. And we cannot give exact incidence because the incidence have been changing by pneumococcal conjugate vaccines. What are the predisposing factors that lead to sinusitis? Anyone with rhinitis, with allergic rhinitis or non-allergic rhinitis. If there is anatomic defects in the area like septal deviation, like middle turbinate enlargements, guanal atresia, adenoids even. Hormonal conditions like pregnancy and hypothyroidism, gastroesophageal reflux, immune deficiency, whether primary or acquired immune deficiency. All these patients can easily develop sinusitis. And the pathophysiology, which starts in the viral upper respiratory tract infection or allergic rhinitis or even passive smoking, it blocks the outflow tract of the sinus and impair the mucociliary clearance. This impairment is isolated in hemolytic cilia syndrome and cystic fibrosis. This will lead to retention of secretions within the sinuses. These secretions are good medium for the growth of bacteria. And now there will be a negative pressure in the sinus that predisposed to sinusitis. The acute sinusitis, usually aerobic bacteria, the major three of the otitis media that we mentioned. But if the condition persists and became chronic, mixed flora, anaerobes, and even fungus will be among the etiologic agents. What are the complications? Do you consider bacterial sinusitis benign or serious? Let us see the complications to see it's benign or serious. We have orbital complications, we have intracranial complications, and we have others. And if you look to the orbital septum, the ones that I showed in red, there is a periorbital area or space. The one in front of the orbital septum is called the preseptal area, and the one behind is called the postseptal. And you look to the complications when it involves the orbit, we have 5 degrees. The red color is cellulitis, the yellow is pus, and the blue is the globe in the middle. And you can see you can have cellulitis, preseptal, orbital cellulitis behind the globe, subperiosteal abscess, orbital abscess, and cavernous sinus thrombosis. And these are the 5 degrees or grades of the orbital cellulitis. And the more you go from 1 to 5, the more will not be an issue of eyelid edema or erythema. No, there will be chemosis of the conjunctiva and proptosis, and maybe even decrease in the extraocular muscle movements and high fever. And this is life-threatening and vision-threatening condition that necessitate CT scans of the orbit and consultation of the ophthalmologist. And you can see the one on the left is preseptal cellulitis, while on the right is orbital cellulitis. You can see the proptosis, you can see the chemosis and edema of the conjunctiva, and definitely the child is in pain when his eyes move. Another picture of orbital cellulitis, another pictures you can see orbital cellulitis, believe me, is not a benign condition. Intracranially, we may have brain abscesses, subdural and frontal, and also meningitis. Again, this is life-threatening. CT scan is highly recommended, and we need to consult a neurosurgeon, and probably we must start IV antibiotics immediately. Other complications which may appear as if they are less serious, but they affect the school performance, the sleep pattern, missing works for the parents, and complications of the antibiotic therapy and the diagnostic procedure, so a bad quality of life. Let's go to the management, and we'll pass through 3 points: the imaging, the antibiotics, and others. What about the imaging? Do we need imaging studies to diagnose acute bacterial rhinosinusitis? Do we need CT scan or MRI? Look to the recommendation of the American Academy of Pediatrics. We should not obtain imaging studies simply to distinguish between acute bacterial sinusitis from uncomplicated common cold or viral upper respiratory tract infection. Although if we suspect or diagnose orbital or CNS complications, we must obtain a contrast-enhanced either CT or MRI with contrast. Remember that the sinuses are involved in all common colds, and if you do for a one who have a common cold sinus imaging, you will find abnormality, but this cannot diagnose sinusitis. So sinusitis is a clinical diagnosis, and imaging is only required in certain conditions. So there is no imaging in uncomplicated upper respiratory tract infection. What about if you decided you suspect complication and you need to do CT or MRI? Which is better? According to the American College of Radiology, you will find each one has the pros and cons. The MRI with contrast is more sensitive and definitely no radiation exposure, but it has the problem it takes longer time, longer than the CT, and usually requires sedation, which carries, or even anesthesia, which carries its own risk. On the other hand, the CT is more available, cheaper, faster, but carries the risk of radiation exposure. So MRI is better, but has a limitation of long time. However, MRI with contrast should be performed if the data of CT scan is not so confident while there is clinical concern. So it's a clinical diagnosis, radiology is indicated only selected in you. What about antibiotics? And I show you the discrepancy, although these two successive years in the same country in the United States, that's the American Academy of Pediatric guidelines. To give or not to give antibiotic, and if yes, which antibiotic? Look, we mentioned that you diagnose sinusitis according to the symptoms, the clinical presentation, whether persistent or severe or worsening. And then you have three scenarios, either uncomplicated, without coexisting illness, or sinusitis with complication, orbital or intracranial, or sinusitis with coexisting condition like acute otitis media, pneumonia, or pharyngitis. You can see the green boxes, all of them antibiotics are indicated except one box. If the symptoms are persistent form of sinusitis, uncomplicated, with no coexisting, you may wait for another 3 days before you start antibiotics. So in the vast majority, you will need antibiotic therapy, except in one box of the 9 boxes. For me, I'll tell you, give antibiotic once you diagnose acute bacterial rhinosinusitis, because complications are really serious. The question is which antibiotic, and we have 3 scenarios: uncomplicated, or a patient who is acutely ill and toxic, or patient allergic to penicillin. If uncomplicated, according to the American Academy, you can give standard dose of amoxicillin, and in communities with resistance, high resistance to strep pneumonia, you need to use high dose amoxicillin, and ceftriaxone is an alternative, either IV or IM, single dose for those who cannot tolerate the oral medication. So the American Academy did not mention so far in uncomplicated cases the amoxicillin clavulanic. What about the patients who are ill and toxic? Well, either immediate otolaryngal consultation or immediate IV therapy with cefotaxime or ceftriaxone. And if he didn't improve, you refer to the otolaryngal consultation. So we have 2 types. If the patient is severely ill, acute, toxic, either immediate referral to the ENT, he will do sinus aspiration, culture, and will give appropriate antibiotic, or you will start 3rd generation cephalosporin IV, and if he doesn't improve, you will refer. What about patient allergic to penicillin? If it is type 1 immediate anaphylactoid type of allergy, you can use cefdinib, cefuroxime, or cefotaxime. But those in children who are below 2 years with serious type 1 hypersensitivity, you need to give a combination of clindamycin or linezolid with cefixime. Linezolid will cover the strep pneumonia, even the most resistant ones, and the cefixime can cover the beta-lactamase producing Haemophilus and Moraxella catarrhalis. Now let's get to the IDSA, Infectious Disease Society of America, and you will find that he recommended the empirical antimicrobial therapy as soon as the diagnosis. So unlike the other one of the American Academy who have 1 in 9 chance to wait and see for 3 days, no. The ETSA recommends immediately. And what antibiotic? They recommend amoxicillin clavulanic and not amoxicillin alone. And they said you will use the high dose if these factors are present. If you are coming from an area or living in an area with high resistance, more than 10% of non-susceptible strep pneumonia with severe infection, for those who go into daycares, for those aged below 2 years and more than 65, if there was antibiotic use in the last month, or in immunocompromised. So you will find that almost everybody will take the high dose of amoxicillin clavulanic. So they asked questions. Do we start with amoxicillin clavulanic, or can we use amoxicillin? And the answer was clear, regardless of the age. No, you cannot use amoxicillin. You can see this is different from the American Academy. What if the patient did not respond to the initial? And what do we mean by non-responder? Non-response deteriorates within 48, 72 hours, or did not improve in spite of treatment 3 to 5 days. Now you need to go to the algorithm, and the algorithm will ask about the resistance. So Risk of resistance. If no risk of resistance, that's called empiric first line, amoxicillin clavulanic standard dose. If there is risk of resistance, empiric second line, which is amoxicillin clavulanic high dose or respiratory quinolone for the older patients. And this is the risks of resistance, the what that I mentioned before. Then, if those who started the empiric first line therapy, the standard dose of amoxicillin clavulanic, they need to continue for 5 to 7 days. But if they did not improve, they need to do a CT or MRI may be needed, referring to a specialist who may do sinus or meatal cultures. But those who started from the beginning with the high dose second line, the duration of therapy would be 7 to 10 days. And again, if they didn't improve, you will refer to a specialist. So the duration varies. For those who use standard dose, this means that it's mild. There is no resistance, you will give it 7 days. For those who will start with high dose amoxicillin clavulanic, you continue for 10 days. And that's the organism. For failure, you need to switch to different antimicrobials. So if you started amoxicillin, which is not recommended by the ETSA, you will shift to amoxicillin clavulanic. If you started by amoxicillin clavulanic, you will shift to a quinolone. Another question that's raised by them and answered by them, should we start with a respiratory quinolone instead of the amoxicillin clavulanic? And the answer was no, no need for respiratory. Do we need to cover staph, for example, to give linezolid or something anti-staph? The answer was no. Can we start with macrolides as a second line or a second oral cephalosporins, second generation or third generation cephalosporins? And the answer is no. The second line is classically either high dose amoxicillin or respiratory quinolone. So we cannot start with macrolides or whatever. Duration of therapy, they mentioned another duration here. In the algorithm, they mentioned something, and here they mentioned another thing. Empiric therapy for child, 10 to 14 days, for adults, 5 to 7 days. Now we go to the other factors. Saline irrigation, is it useful? The answer is yes. It is recommended for the management of acute bacterial rhinosinusitis. Intranasal corticosteroids, yes. It is recommended as an adjunct therapy. It's not the treatment, it's part of the treatment. So we give saline irrigation intranasal steroids. The guidelines of the ETSA recommends against the use of decongestants or antihistamines, whether oral or intranasal. And that's a common mistake, that people use the antihistamines for the treatment of sinusitis where there is recommendation against. So the take-home message, I'm sure you are now happy that we will finish soon. The take-home message that acute bacterial rhinosinusitis is not uncommon. It has potential serious complications. The triad pathogens of acute otitis media are the same: strep pneumoniae, Haemophilus, influenza, Moraxella catarrhalis. Acute sinusitis usually preceded by viral respiratory tract infections. Usually the patient have rhinorrhea and daytime cough that worsens at night. There is nasal obstruction and other symptoms: fever, headache, fatigue, halitosis, anosmia, facial pain. And the American College of Radiology endorses the MRI and the CT only when there is potential complication for sinusitis, and each has the pros and cons. To see the antibiotic in just one slide, that's the two different antibiotics, and you can see that the American Academy did not mention amoxicillin clavulanic. In fact, they use either standard dose or high dose amoxicillin, and for non-tolerance, they use ceftriaxone. This is not the case at all in the Infectious Disease Society of America. I'll tell you my opinion. We have 3 microorganisms. One of them is non-beta-lactamase producers and 2 beta-lactamase producers. And I would give an antibiotic definitely with beta-lactamase inhibitors, because if you give amoxicillin, as the American Academy of Pediatrics says, you are sure in a proper dose you can treat strep pneumonia, sinusitis, but you cannot treat Haemophilus influenza and Moraxella if they produce beta-lactamases. And the standard or high dose depend to what extent we anticipate a drug-resistant pathogen in the community and the patient. Please also remember that we need not to abuse the antibiotics. Thank you very much.
Thanks a lot, Professor Ahmed. And I wish that you will have a second presentation, but we are unlucky.
I'm sorry, Wallahi Nabi. Thank you.
If anyone has a question, we can start. Dr. Ahmed, I have a question from our colleague here. Is there any relation between COVID and sinusitis?
Not exact relation, you know. COVID came with, destroyed all our knowledge in medicine, because yes, you can have COVID with no symptoms at all. And we were going to a meeting, a medical meeting. We were 100 doctors. We were asked to do the PCR before going, and 13 of us proved to be positive, although they have no symptoms. So COVID can come with anything. And of course, sinusitis can be part of this anything. The question, did we see more sinusitis during the COVID? In fact, not, because the isolation reduced the upper respiratory tract infection. Everybody knows that the respiratory tract infections, including the flu and all of them, were reduced because of the isolation and the quarantine. And that's why we didn't see more sinusitis during the COVID era.
Okay. So anyone has any question? You can write in the question and answer. If not, so we'll proceed to our next speaker. Okay, thank you, Dr. Ahmed, for being with us.
Thank you, Dr. Nabil, and good luck and have a nice day.
To have you with us. Thank you very much.
Salam.
You can stop sharing, Dr. Ahmed. Shukran. Now we'll go to our next speaker. Will be Professor Dr. Mustafa Al Said. He is a consultant and the head of department of Saudi German of dermatology and andrology in Saudi German Hospital Riyadh. Dr. Mustafa is a professor of dermatology and andrology in Al Mansoura University. Dr. Mustafa will speak to us about the chronic bullous diseases of childhood. Okay, Dr. Mustafa, you can start.
Assalamu alaikum. I appreciate Dr. Nabil, the chairman of the conference, and the Saudi German Hospital Riyadh administrative staff for giving me this chance to show in this conference. I will speak today about chronic bullous disease of childhood, or as another name, linear immunoglobulin A bullous dermatosis. Our objectives, well, started by some definitions, as we are in Derma have our special definitions. Second, we'll show the disease case presentation from our hospital, Saudi German Hospital Riyadh, then differential diagnosis and management. First definitions, we have the vesicle. The vesicle is a circumscribed elevation less than 1 centimeter in diameter that contain liquid, either clear, serous, or hemorrhagic. When it's become larger, more than 1 centimeter, it calls a blister or bull. The pustule, when they contain virulent material. Erosion, loss of either a portion or whole of epidermis. Ulcer, loss of the whole epidermis and part of the dermis. Here is the vesicle, and here is the blister. This is herpes zoster, and this is bullous photodermatosis. Here is the pustule surrounding erythema. Here is the crust, consists of exudate serous with dried serum in case of herpes simplex. The distribution may be solitary, grouped, like in herpes, herpetiform like in our disease, linear as in phytophotodermatitis, and randomly as in bullous bemphigoid. The content of the vesicle or poly may be clear, transudate, opaque, serous, or hemorrhagic. This is epidermis. This is the structure of the skin: upper epidermis, mid, lower, basement membrane. The keratinocytes are connected with each other by desmosomes, and with the basement membrane with the hemidesmosomes, which have many protein and structure protein connect the epidermis with the dermis. So we'll come to our disease, which is defined as chronic bullous disease. It's a subepidermal disorder that characteristic clinically by bully and with linear immunoglobulin A deposition at basement membrane zone, noted on direct immunofluorescence of perilesional skin. It is also known as linear immunoglobulin A bullous disease. It is a rare acquired autoimmune blistering disorder. However, it is the commonest in children, most often in children younger than 5 years. It can occur at the age of 6 months or less, even to 6 years of age. Occasionally preceded by upper respiratory infection, may be idiopathic or drug-induced, or following vaccination. What the factor associated with chronic bullous disease of childhood? As an autoimmune, it may be associated with malignancy, lymphoproliferative disorder, solid tumor, gastrointestinal diseases as inflammatory bowel disease, drug-induced. Vancomycin is the most common. However, it can occur with many other antibiotics. The pathophysiology, as we said, it's an autoimmune disease related to antibodies directed against the hemidesmosomes. Okay, this is immunoglobulin, bullous bemphigoid immunoglobulin 80, 180, and 230 is mainly directed. The antibodies are directed to the target antigen, which is 120 kilodalton. It's LAD1, 97 kilodalton, lab D97. It is the ectodomain of bullous bemphigoid 180. It is this part. Okay. And circulating immunoglobulin antibodies directed against LAD antigen. The matter is not simply like this, but it is a complicated at which binding of the autoantibodies to bullous bemphigoid 180 initiate complement mediated, leading to release of cytokines from basal keratinocytes. Complement is activated at the dermo-epidermal junction. We'll see in another photo, and mast cell degranulate. Complement activation, chemokine gradient results in infiltration of inflammatory cells and secretion of inflammatory mediator with reactive oxygen species that ultimately induce dermal epidermal splitting. Also, matrix metalloproteinases 9 have a role in cleavage. This is the same photo with large size. Complement activation, chemokine, cellular infiltration, release of cytokine and matrix metalloproteinase, and finally separation at the dermo-epidermal junction. The histopathology is a subepidermal blister, as we see here, subepidermal blister with dermal inflammatory infiltrate of mainly neutrophil and some eosinophils. Occasionally, eosinophils form microabscesses at the tip of the dermal papillae. Direct immunofluorescence here. This is showing linear immunoglobulin A at the dermo-epidermal junction, and salt split technique show fluorescence on the epidermal side of the blister. Here is the linear deposition of immunoglobulin A. The clinical picture, tense bully. It may occur on any area of the body, but usually lower trunk, buttocks, feet, and widespread lesion may involve the whole body, including face, scalp, upper trunk, hands, and arms. Lesion erupt on red as well as normal appearing skin and form a ring composed of sausage-shaped bully around a central healing blister. This is the bully clustered around the main one. This is erosion after rupture of the blister. And the string of pearls, or sometimes called cluster of jewel sign. Mucous membrane are not usually involved. Nucleus sign is not present. and some children are completely asymptomatic. Here is the string of pearls. There is a main pulley with surrounding small pulley, sausage-like, or string of pearls. Again, string of pearls or sausage pulley around a central pulley. Again, sausage may occur around the neck and around the mouth. The pulley is tense and this is ruptured. Again, on the genitalia, around the mouth, in hands, in ears, with the direct immunofluorescence linear immunoglobulin A deposition. We will present a case which is in collaboration with Dr. Samira and Dr. Nabil in our SCGH Riyadh neonatal in ICU. It was a preterm baby, 26 weeks of gestation, was delivered outside the hospital, received for prematurity, and was transferred by midvac for photocoagulation for retinal separation. The ophthalmologist decided to do Lucent intravitreal injection and was done to be followed up. There was central line for TPN and medication. After 2 weeks, the baby developed sepsis with thrombocytopenia, and we changed the central line to peripherally inserted catheter. Intravenous antibiotic and antifungal were started. There was the antibiotic taken was amikacin and tazocine. After that, the patient developed bully, started in the neck and extended to the right upper limb, progressively including the limb within 24 hours. The second day, some bully appeared on the left upper limb, genitalia, buttock, left foot, and oral cavity. Here is the pulley, tense pulley arranged around the central one, in the feet. Treated by intravenous immunoglobulin G 1 gram per kg per dose for 3 days and methylprednisolone 1 milligram per kg per dose for 3 days, then gradual withdrawal with topical antibiotic. The patient was significantly improved with maintenance on topical creams. Here, okay, improving, and finally he was almost completely improved. Our diagnosis was drug-induced chronic bullous disease of childhood. However, the DIF, direct immunofluorescence, was not available. The drug-induced variant of chronic bullous disease of childhood was considered because the patient was exposed to various medication. Consistent with our cases, drug-induced, the patient's skin lesion respond well to treatment with systemic prednisone. There was almost the same case like our case. It's published in Journal of American Academy of Dermatology in 2010, in which neonatal chronic bullous disease showing the tense bully and was treated with antibiotic, including amikacin and piperacillin tazobactam, and was treated by prednisone 0.5 milligram per kg per day, tapered along 1 month. Here is from screenshot from the Journal of American Academy of Dermatology. The differential diagnosis, the most important is to differentiate between bacterial infection and that disease, which is autoimmune. In bullous impetigo, the involvement is focal, mucous membrane are not involved, blister rupture easily with peripheral collarate of scale, and flaccid bully, ruptured forming round or crusted erosion, and vesicle occasionally present, forming what we call hypopyon sign. And the main is that gram stain culture will reveal Staph aureus. Here is the pustule with surrounding erythema with hypopyon sign after rupture, leaving crust with collarate scale. The other differential diagnosis includes herpes simplex viral infection, most common around the mouth, often occur inside or around the mouth, tend to be painful and less often pruritic, mostly focal. Arthropod bite, papular, or sometimes called bullous papular urticaria, after exposure to insect bite. It usually may be taken linear papule with history of exposure to insect bite. Also, scabies in neonates may be bully, with family history, with itching, increase at night, with other family member. Pityriasis lichenosis varioliforme acuta or syndrome, it's occur but it differ because the lesions are scaly, papule with necrotic surface associated with fever. This is our case, linear bullous dermatosis with sausage-like cluster of jewels. Bullous lupus erythematosus, it's usually occur in extremities. The patient has other criteria of confirmed diagnosis of systemic LA. Direct immunofluorescence and immunoblotting help to confirm the diagnosis. Bullous pemphigoid, it differs from our disease by immunofluorescence, in which the deposition of hemoglobin A at the floor, not the roof of the pulli. Also, we have other mechanobullous disease, epidermolysis bullosa, which usually affect the sites of trauma, mostly the limbs, may be associated with scarring according to the level of cleavage, and also acquired epidermolysis bullosa, which is associated with blister, also induced by trauma. Scarring is common with direct immunofluorescence directed against collagen 7 at the dermo-epidermal junction. Treatment of chronic bullous of childhood, however, it is self-limiting. Some cases may complete up to adulthood. Treatment is aimed at controlling blister while avoiding adverse reaction. Many children are exquisitely sensitive to small doses of dapsone, and resistant cases may require systemic corticosteroid until control of the eruption. Topical corticosteroids can help in mild cases, is effective as a single agent or as an adjuvant to limit the dose of systemic steroid. There is a line, first line including the dapsone and topical steroid, second line including prednisolone, azacitidine, third line including colchicine, intravenous immunoglobulin, even antibiotics and mycophenolate mofetil. The dapsone is considered the drug of choice. Start with low dose, less than 0.5 mg per kg. Before starting, we should check for G6PD deficiency and methemoglobinemia. Dapsone has its own side effect, including idiosyncratic adverse reaction like agranulocytosis, GIT, cutaneous hypersensitivity, and we should pre-order laboratory evaluation, CBC, liver, renal, and basically G6PD enzyme level. Also, sulfapyridine can be used, or together addition of systemic steroid may be needed to control, and topical corticosteroid also. Children with G6PD deficiency may use colchicine systemic steroid if the dapsone is contraindicated. Other possible treatment, there is a recent case, but the disease was severe. They use rituximab, which is monoclonal CD20 that used in lymphoma, and the patient was treated after failure of dapsone systemic steroid. They use rituximab 250 mg given 15 days apart with a dramatic resolution of the lesion after 4 weeks of therapy. So to take home message, don't forget chronic bullous disease, which is a subepidermal immunoglobulin disorder. And first, before starting steroid or any other immunosuppressive drug, exclude bacterial infection by culture and swab. Most of the children are sensitive to small doses of dapsone. However, resistant cases may require systemic corticosteroid or other immunosuppressive disease. Thank you.
Thank you so much, Mustafa, for your nice presentation. If anyone has questions for Dr. Mustafa, can write. Okay, so we'll go to our next speaker. Can stop sharing, Mustafa. Our next speaker will be Dr. Fahd Al-Habshan. Dr. Fahd Al-Habshan is the consultant and chief of the medical pediatric cardiology division in National Guard Hospital, Riyadh. Dr. Fahd is one of the most eminent pediatric cardiologists in Kingdom of Saudi Arabia. He will speak to us about two topics. The first one is neonatal cardiac emergencies. The second one is approach to cyanotic newborn. Welcome, Dr. Fahd, and thank you for being with us. You can start. You can share your...
Thank you very much, Dr. Nabil. Can you see
Just
my...
do a full screen and I can hear you well.
Okay. Okay. Can you see my slides?
Yes.
Okay. Thank you very much for the invitation, and congratulations for this putting together this nice conference. I really envy your perseverance, because to do something good is not easy, but to persistently doing it every year with the same quality is something amazing. So congratulations for this.
Thank you so much.
The topic I was given is the neonatal cardiac emergencies. And this is a very important topic, because according to the WHO numbers, about 30 to 40% of the mortality of the live newborn babies is related to congenital malformation. And 28% of the congenital malformation death is related to cardiac malformation, because cardiac malformation is the commonest malformation in human being, if we take it by systems. I will go over this topic by showing brief cases. Each case is going to deliver a message. So hopefully at the end, we'll take some important messages from these cases. So the first case is a 2-week-old baby. By the way, these are real cases. I'm not showing anything from the internet. These are real cases that we have seen. So this is 2-week-old baby that was brought to the emergency room by the parents due to feeding difficulty, lethargy, vomiting for 2 days. So if you get a baby like this in the ER, how would you proceed? Usually we start by taking history. History taking is very important to elaborate the details of the case, and then do a proper physical examination head to toe, and then do the most important investigations. So if we think about the history, this baby was well in the first week of life. Then the mother noticed that the baby started to be unwell, even though there was no fever, but there was progressive feeding difficulty, as she described. And then the baby started to have vomiting, and then he became lethargic, and then he started to have shortness of breath. On the physical examination, the baby was sick, pale looking. He had weak pulses all over with cold extremities. His capillary refill was 6 seconds. He was tachycardic with a heart rate of 200 per minute, tachypneic with a respiratory rate of 60 per minute, and his blood pressure was 50/35. So from this picture, how would we describe this baby? This baby definitely is in shock. So how would any resident or any physician, pediatrician manage this baby in the emergency room? The most important thing is to start with ABC. Always remember your ABC, regardless whether it is a cardiac case or not cardiac case. Always remember the ABC. So this baby should receive resuscitation starting with the airway. This baby was breathing on his own, and his airway was patent, but his circulation was the main problem. So stabilizing the baby should start with a bolus of fluids, and then reassess after giving the first bolus or even the second bolus, and then think about the possibility of causes for such presentation. The commonest cause of a presentation like this is infection. So always remember infection. Don't think about metabolic, endocrine, whatever, before thinking about infection. And infection can present in concurrent presentation with other emergencies, like with metabolic or endocrine or cardiac or anything else. So please always remember to consider the infection and to treat the infection properly. And then thinking about the physical examination, This baby in the reassessment, there was a significant murmur in the left upper sternal border. It was grade 3/6, and he had weak pulses still even after the second bolus. The tachycardia became less, but the weak pulses were there all the time. So other possibilities like metabolic, endocrine, GI disorder, or seizure disorder should always be kept in mind during the assessment. When we assess, we should always compare the pulses between upper limb and lower limb. And this baby had weak lower limb pulses all the time. So one way to differentiate also is to use the oxygen saturation, differential oxygen saturation between the upper limb and lower limb to see if there is a difference in the oxygen saturation. And this is important to differentiate whether there is, for example, an arch obstruction like interrupted aortic arch or coarctation of aorta. Then the flow from through the ductus arteriosus will be the one to feed the lower part of the circulation. So the lower part will have lower oxygen saturation than the upper part. In extreme rare cases, the upper part might be lower than the lower part, like in a baby with a coarctation of aorta and transposition of great arteries, for example. So this baby actually had a coarctation of aorta, which is the cause for the systemic outflow tract obstruction in this baby. And again, how do we manage this? Always remember your ABC. Don't jump to medication or don't jump to big conclusions before doing the standard ABC management for such patient. So after the second bolus, by hearing the murmur, there was abnormal ECG and chest X-ray. So this baby was started on prostaglandin. If you suspect that there is a congenital heart disease that is affecting the life of the baby, please start prostaglandin before calling the cardiologist. Some people wait for the cardiologist who might be at home or not available in the hospital, or wait to transfer this baby to a place where there is a cardiologist to assist the baby. You don't need that. You can start prostaglandin and then do the consultation or referral or whatever. So babies with systemic outflow tract obstruction like this baby, the systemic outflow tract obstruction can be at a different level. It can be like supramitral, below the aortic valve, at the aortic valve, severe or critical aortic stenosis, or the commonest is aortic coarctation. These babies, usually they are well at birth. This is the classical presentation, that they are well at birth because the ductus is wide open. And then as the ductus start to close, as the ductus arteriosus start to close, they go into shock. And if you happen to catch them before going into shock, you will notice that they will have weak femoral pulses compared to the brachial pulses or the upper limb pulses. And if you check the blood pressure, you will notice that the upper limb has higher blood pressure, at least 10 millimeters of mercury higher than the lower limb. In the normal situation, the lower limb should have higher blood pressure than the upper limb. And there will be a differential oxygen saturation where the arm will have a saturation that is more than 3 digits higher than the lower limb saturation. So for example, if the hand saturation is 97, you may find the lower limb saturation, for example, 94, 93, something like that. The chest X-ray may show plethoric lung, or sometimes it might be normal. In the initial stage, it might be normal. And usually ECG may show right ventricular hypertrophy. Babies with arch obstruction in particular are those that need to pay attention. The arch obstruction can be a coarctation, or it can be an interrupted aortic arch. These are the types of interrupted aortic arch. It can be type A, where the interruption is after the last branch of the transverse arch, or it can be type B, which is between the left common carotid and the left subclavian artery, or it can be type A, which is before the left common carotid, between the two carotids. So these types of arch obstructions can present in shock with similar presentation to the baby I just presented. And then always remember, if you get a baby who's coming in shock, who was well in the first week of life, no fever, no obvious fever, no one is sick at home, there is weak pulses, there is difference in the blood pressure, always remember the arch obstruction, because the treatment management can be life-saving, because time matters for these babies. If you delay starting prostaglandin, the baby may succumb and may die because of this complication. This is another baby who had a similar presentation. He was almost 3 weeks or 4 weeks old, actually, when he presented. But this baby, in addition to the presentation, which was very similar to the first one, like he was well for 2 weeks, and then he came with worsening shortness of breath. The baby did not reach shock yet, but when he came to us, he was very sick with severe tachypnea, tachycardia. There was cardiomegaly on the chest X-ray, and then the baby was seen in another hospital and diagnosed to have congenital dilated cardiomyopathy. And the cardiologist who saw him was right, because the baby had severely dilated ventricle. As you can see here, the left ventricle is severely dilated with severely depressed ventricular function. But the message from this case is that babies with severely depressed function that present early, it could be congenital or it could be secondary to aortic arch obstruction. As you can see here in the 4 chambers view, you see that this baby has severely dilated left atrium and left ventricle with poor contractility of the left ventricle. So this baby actually had a coarctation of aorta. You see, this is the aortic arch, this is the ascending aorta, this is the transverse arch, and that is the descending aorta starting at the isthmus of the aorta. And there we see a constriction that is opposite to the ductus arteriosus. You see, this is a very small closing ductus arteriosus, and this ductus arteriosus, as it closed, that area constrict, and that was the reason for the depressed ventricular function of this baby. So again, systemic outflow tract obstruction may present in a similar case to dilated cardiomyopathy. So if you happen to receive a baby who has a hugely dilated heart, and if you happen to be skillful in doing bedside ultrasound or what's called point of care ultrasound, and you see a dilated ventricle with poor contractility, always keep in your mind the possibility of systemic outflow tract obstruction. So the similar management, prostaglandin is life-saving in these babies, and they need to be referred to cardiac center as early as possible for arch repair, or if they have severe hypoplasia of the left side, might be univentricular repair. Second case, this is again another true case that we received a few years ago. It was about 4 weeks old baby. Mother noticed that the baby was not gaining weight. He was referred because there was a murmur and some tachycardia. This is the baseline ECG of the baby. There was persistent tachycardia, but there was widening of the QRS. And then if you notice here that the widening is at the beginning of the QRS, usually with the bundle branch block, the widening is at the end of the QRS, not the beginning. So this baby has a widening at the beginning of the QRS. And then on the next day after admission, this baby had this ECG. This is the ECG of the same baby. So this baby had this kind of ECG. This baby was going on and off into very fast supraventricular tachycardia. And that widening of the QRS was actually due to the early depolarization of the ventricle. This baby had WBW, or Wolff-Parkinson-White syndrome. In these babies, you see, after the atrial contraction, normally we should have a PR interval. The PR interval represents the delay that happens in the AV node, because the impulse does not cross from the atrium to the ventricle directly, because we have a dense fibrofatty tissue that prevents any impulse to conduct from the atrium to the ventricle directly. The only way for the impulse to go is through bundle of His. These babies, they have an accessory pathway, and then the impulse may travel through this pathway and then travel through the muscle, but to go through the muscle, it is slow. That's why this early repolarization during the time of the PR interval, and then the normal impulse will come up. So this delta wave, which is called the delta wave, which is the early depolarization of the ventricle immediately after the P wave during the PR interval, is due to this accessory pathway. And then during this arrhythmia, what happens is that this pathway functions as a re-entry circuit where the impulse comes down through the normal pathway and then go back through this accessory pathway and then go to the normal pathway again and keep rotating and rotating and rotating very fast. And this fast tachycardia, like this one, will cause heart failure and difficulty in breathing, difficulty in feeding, failure to thrive, similar to this baby. So if you get a baby who is like the mother described him being unwell most of the time. His heart rate is on the faster side. And you see an abnormality in the baseline ECG, something like this, with widening of the QRS. Think about the possibility of a WBW syndrome and think about the possibility of supraventricular tachycardia. The management of this patient can be during the tachycardia by applying vagal maneuvers like a Valsalva if it is a bigger child, but in small babies and neonate, we use ice on the face. Ice bag, you put some ice in a bag and you put it on the face of the baby, and that may help to stop the tachycardia. If that does not work, then you can use adenosine. To use the adenosine, use it properly or don't use it. To use it properly, you need a good IV access, rapid flush, and you need to give it by an increasing dose. The first dose is 0.1 milligram per kilo, then 0.2, then up to 0.3 milligram per kilo. If that does not work, or if you break the tachycardia and then you want to give a maintenance, you give a maintenance of oral beta blocker, or if the adenosine did not work, we can use IV beta blocker, but we should use something like osmolol that has a short half-life that can be stopped easily. Oral amiodarone can be used for the maintenance of treating such a baby. Another case that presented in an emergency situation, it was a newborn baby. This baby was a full term, 3 kilo, very well at birth. His vital signs were good at birth. He was very well looking, except a slow heart rate. So if you follow the NRP guidelines, a baby who has a heart rate of 60 beats per minute at birth should have a CPR started, isn't it? So we should start by stimulating the baby and doing chest compression. But I'm describing this baby to you by being very well. He's looking at you, he's crying, he's sucking, he's breathing well, he's not in distress, his oxygen saturation is normal. So what should I do in this case? I should obtain an ECG. So this is the ECG of the baby that was obtained. If you see here, this baby has multiple P waves. You see, this is a P wave, this is a P wave, this is a P wave, this is a P wave. He has multiple P waves, more than the QRS complexes. This baby actually has a congenital complete heart block. So this may present either in a compromised situation or uncompromised. This baby did not have a compromise. Some of them may have hypotension or symptomatic bradycardia. Some of them, they don't have. Actually, majority, they don't have. So if you face a baby like this, think about the possibility of a heart block, and we should examine the heart. We should do echocardiography to see, is the heart structurally normal or abnormal? The commonest is seeing this in a structurally normal heart, and this is usually related to lupus antibodies in the mother. The mother may not know that she has these antibodies until she delivers a baby who has a heart block. So if we find a baby like this, we can just observe. We don't need to do anything. If the baby is well and the heart rate is above 60 with a normal structure of the heart, then this baby can be discharged and followed later on. But these babies, at some point in their follow-up, they will require a pacemaker because they may develop complication from this. The complication may start in utero before the birth. Some babies develop hydrops fetalis. Hydrops fetalis is one of the highest risk for mortality in these babies in utero. They may develop also pericardial effusion and they may die in utero. The indication for the pacemaker insertion, if there is intolerance to feeding, if the baby has symptomatic bradycardia with heart failure symptoms, or if there is a depressed function on echocardiography, or the QRS or the ECG shows wide QRS complexes. If they are narrow, like the one I just showed, then we can observe. Or if the heart rate is less than 50 beats per minute in a normal heart, or less than 70 beats per minute with congenital heart disease. As I said, if you follow these babies, all of them, almost all of them, at some point, they will require a pacemaker. We try to delay it as much as possible, as long as the baby is well, because if you implant a pacemaker, you need to replace it within 3 to 5 years, because these pacemakers, they have batteries and they need to be replaced. Another case, similar case to the previous presentation, but this baby, he was well in the first 2 weeks, and then after that, mother noticed that he has excessive crying, very irritable baby. And his crying did not settle with feeding. Usually babies, when they cry and they feed, they settle on the feed. This baby, after the feeding, he gets worse. He has sweating, he's like shivering, irritable, he's very irritated, and he's crying a lot, and he has poor weight gain. On examination in our emergency room, this baby was afebrile, heart rate was 170 beats per minute, respiratory rate was 80 per minute, he was tachypneic and tachycardic, and there was intercostal retraction, and the liver was enlarged. This is the initial chest X-ray that was obtained by the emergency room pediatrician, and it shows clearly a very large heart. You see the heart is reaching the border of the chest here. This is a big heart, and the lungs don't show major infection. And this baby had no fever, and his CBC was not showing high white cell count. There was no indication with a high CRP or indication for any infection. But this is the ECG of the baby. What do we notice here on this ECG? You see here there is ST elevation. If you look at V4 and V5, look at V4 in particular, you see that there is the ECG, the baseline, which is before the QRS, is much lower than the baseline, which is after the QRS. So there is significant ECG elevation. And if you look at the T wave in lead 2, 3, and AVF, you see that the T wave is inverted. Normally, T wave should not be inverted in small babies except in AVR and in V1, V2. Other than this, all of the T waves should be upright. This is clear T wave inversion in V2, V3, AVF, with ST elevation in V4, V5. This baby actually has ischemia with tachycardia. This is one of the common emergencies that may present, and these babies, unfortunately, they don't have murmur. But if you do echocardiography, you see this is one of our babies who presented. The top left on the corner, the one with the weakest function, actually this was the echo at presentation. If you catch these babies early and you get the proper diagnosis, this patient may survive very well and actually may regain completely normal function. You see, this is the last echo lower down is the last follow-up, which is about 6 months after operating on this baby who has anomalous left coronary artery from the pulmonary artery. So this is the classical presentation for these babies. They have ischemia and they have angina. This angina happened during exercise. What is the biggest exercise a newborn baby will do? It is feeding. This baby, when he feeds, he becomes sweating and he becomes irritable and he cries a lot. So that excessive crying after feeding is an alert. If you see a big heart in the chest X-ray, if you see a poor function by ultrasound, if you happen to use ultrasound in your emergency room, think about the possibility of Al-Kappa or anomalous left coronary artery, which require an emergency referral and emergency treatment, and you can save this baby, and the baby may regain completely normal function by proper management. This is the last case I'm going to show for a newborn baby. Actually, there was a similar case in Saudi German hospital a few months ago for a baby who had stridor that started immediately after birth. This baby, when we saw him, he was about 2 weeks old, and this baby had stridor since birth with respiratory difficulty. Because of the respiratory difficulty, there was some failure to thrive. Baby was not gaining weight. The baby had normal heart rate, but he was tachypneic. His oxygen saturation was completely normal. He was using the accessory muscles, and there was wheeze, but there was no murmur. The chest X-ray showed just mild air trapping, and the ECG was completely normal. The echocardiography showed basically normal structure and function of the intracardiac anatomy. So what would be the important possibility to think about? It's either a congenital malformation in the airway, the commonest of which is like laryngomalacia, tracheomalacia, or it could be something else. So in these babies, we can do a barium swallow. And as you can see here, there is a posterior indentation. This is a bigger child actually. And that baby had double aortic arch. These babies, they have 2 arches. You see, this is looking from the back. This is the descending aorta. This is the right arch. This is the left arch. And these 2 arches are coming from the aorta and they are surrounding the trachea. This is the airway in the trachea, and this is an nasogastric tube that is passed through the esophagus. So this is a complete vascular ring, which is very tight and causing stridor in this baby. Sometimes this vascular ring is related to a right aortic arch and left-sided ductus arteriosus in presence of diverticulum of Kummerer. You see, this is the diverticulum which is behind the trachea. And then looking close up, you see this indentation here because of presence of the ligamentum after the ductus has closed, and this results in airway problem. Airway compression can happen also not only from the vascular ring, but also from the pulmonary sling. Pulmonary sling is defined as having the right pulmonary artery from the left pulmonary artery. This is one of the babies that we had. It is clear that this is the right pulmonary artery and this is the left pulmonary artery, but still we did a CT scan for this baby. So what did I gain by doing CT scan for this baby? The most important thing is to remember that these babies, they can have major airway anomaly in addition to their vascular anomaly. So these babies with the sling, they may have normal airway or they have abnormal. Like this is the airway of the baby with the echo that I showed. They have different level of bifurcation of the trachea, and they have complete cartilaginous ring in this part of the trachea. And these babies may suffer major airway problems. That's why they require early intervention. Sometimes they have normal airway, but they have significant compression of the lower part of the trachea near the area of the sling. This is because of the compression. You see, this is what we call virtual bronchoscopy, where you go through the trachea. This is going to the right bronchus, it's easy, but going to the left bronchus, you see it's very tight here near the origin of the left bronchus because of that significant compression. I would suggest this reference for people if they want to read. It's a little bit old, but it's a very good reference in the pediatric clinics of North America, which is Newborn Emergencies, the first 30 days of life. And it was well written by this team. It's a little bit detailed, but it covers almost all kinds of emergencies, including the cardiac emergencies. Thank you very much.
Thank you, Dr. Fahd, for your excellent presentation. I wish that you can continue with your second lecture, then we can take any questions in the last, after this and after the two presentations.
Okay, sure. Actually, the second lecture is a continuation for the emergencies because it is about the cyanotic newborn. Yes. I skipped the cyanosis in the emergency presentation because it is the title for this second talk, which is speaking about the cyanotic newborn. First of all, we need to know what is the definition of cyanosis. So it's a bluish discoloration of the digits.
You can share the second lecture, sure. It's still the same.
Yes, I will. So. Sure. Can you see that now?
Yes.
Okay.
Make full screen back.
Yeah. So cyanosis can be peripheral or central. The more serious one is the central. And usually it happens due to drop in the level of oxygenated hemoglobin if more than 5 grams per deciliter. That's why it may not be obvious in the anemic babies. Like if the baby has a hemoglobin of 8 or 9, you may not see obvious cyanosis. The other thing is that it may not be obvious in the dim light, like the fluorescent light. You may not see the cyanosis obvious. So you need a good daylight to be able to see the cyanosis. In general, usually you don't see the cyanosis clinically if the saturation is more than 88%. But if it is less than that, you may see it. And it may happen peripherally due to vasoconstriction without having any problem in the heart, just by peripheral vasoconstriction. The commonest congenital heart lesions are the acyanotic congenital heart diseases. And in the acyanotic congenital heart diseases, usually we have a left to right shunt, like the VST, AST, ductus arteriosus, and things like that. But the other type of heart diseases is the cyanotic congenital heart diseases. Like if we have an obstruction for the flow to the lung, like in tetralogy of Fallot, this is an example for tetralogy of Fallot, where we have right to left shunt at the ventricular level. Or if we have an obstruction at the tricuspid valve, like tricuspid atresia, or at the pulmonary valve, like pulmonary atresia or critical pulmonary stenosis, then you may have an atrial shunt with right to left shunt. In this case, if we have ventricular or atrial right to left shunt, then there will be desaturation, lower oxygen saturation from that right to left shunt. these babies, they may have decreased pulmonary blood flow, increased pulmonary blood flow, or a normal pulmonary blood flow. Is it possible to have cyanotic heart disease with increased pulmonary blood flow? The answer is yes. But the commonest is with decreased pulmonary blood flow. The classical is tetralogy of Fallot, and the other examples that I gave, pulmonary atresia or tricuspid atresia. In this case, usually the baby will be dependent on the ductus arteriosus for the flow to the lung. The other thing is with increased pulmonary blood flow, for example, truncus arteriosus, there is sharing between the right side and left side, there is mixing, and there is cyanosis, but the blood flow to the lung is increased. The other example of increased flow, when we have total anomalous pulmonary venous drainage, these babies, they may have cyanosis and an increased pulmonary blood flow. Babies with TGA, they may have increased or a normal pulmonary blood flow, but their problem is the mixing. Sometimes we may have a decreased systemic blood flow and severe cyanosis, like in hypoplastic left heart or severe coarctation. Then the baby might become cyanotic. Mixed lesions, like in babies with complex cyanotic congenital heart disease, like in a single ventricle with Malbos great arteries, sometimes we may have systemic outflow tract obstruction or pulmonary outflow tract obstruction, and we may have cyanosis. How do they present, these cyanotic babies? Usually at birth, they will have established cyanosis from birth. It does not happen later on. So careful clinical examination at birth, the neonatal assessment, is very important to detect cyanosis. The second common lesion is the second common finding is the murmur, heart murmur, presence of heart murmur. Usually these babies, they don't have respiratory distress, but some of them may have respiratory distress, especially those with severe cyanotic heart disease. Sometimes they may present with sepsis-like picture if there is a systemic outflow tract obstruction. In the history, if you dig in the history, usually they have feeding difficulties, majority of them. Some of them may not have, like babies with simple tetralogy of Fallot, they don't have feeding difficulty. Actually, they are usually well-looking babies. They may have sweating, they may have failure to thrive, respiratory distress, cyanosis, or they may present in shock. The approach to these babies, if you get a newborn and the baby has cyanosis and you suspect that the baby has a cyanotic heart disease, always think about the history to differentiate whether this is a cyanotic heart disease or this is a respiratory problem. Always think about the history. When we start with the history, we always should go back to the maternal history. Was there anything in the mother to indicate possibility of congenital heart disease or something else? Like, was the mother diabetic, which increased the possibility of congenital heart disease? Was there any maternal infection like rubella or something that may induce serious congenital heart disease? And then in the history for the baby himself, like fetal risk, was there premature rupture of liquor or meconium aspiration possibility? So this will go with more with respiratory rather than cyanotic heart disease. If you have a baby who had a meconium stained liquor and he's coming with severe hypoxia that is not responding to your initial resuscitation, think about PPHN before thinking about cyanotic congenital heart disease, because the possibility with meconium aspiration in a full-term baby with a meconium stained liquor, possibility of persistent pulmonary hypertension of the newborn is more than cyanotic heart disease. Similar thing if the baby was a premature baby compared to a full-term baby. Preterm labor is one of the commonest causes of respiratory problems and cyanosis in babies. So if you get a baby who was born at 28 weeks, who has respiratory distress and cyanosis, think about premature lungs. Give him surfactant before calling the cardiologist to rule out cyanotic heart disease. Similar thing, whether it was normal delivery or C-section, always ask about the family history. Was there a previous congenital heart disease which increased the possibility in this child, or was there any neonatal death? And then in the physical examination, when we approach a baby with cyanosis, a newborn baby with cyanosis, look at the baby in general. Is this baby well-looking or unwell? A well-looking baby with cyanosis that is persistent is more likely to be congenital heart disease. An unwell-looking baby with respiratory distress in particular might be respiratory or cardiac. Then you look at examine the color central and peripheral, not only the peripheral, and then check the vital signs, check the pulse oximetry. Pulse oximetry is very important to check, especially in the upper limb and the lower limb. If it is less than 95% in any limb, or there is a difference of more than 3 digits between the upper and lower, then think about congenital heart disease. Similar thing for the blood pressure. If the blood pressure in the upper limb is higher than the lower, limb, then it is abnormal. Look at the respiratory rate and the heart rate. If there is tachypnea and tachycardia, it could be either, but if there is hypotension, then it could be more of a cardiac. Assess the femoral pulses. Weak femoral pulses would indicate more a cardiac problem than a respiratory problem, but if the femoral pulses are plus, good femoral pulses, and there is central cyanosis that is equal on both sides, and there is no murmur, then it is more likely to be respiratory rather than a cardiac cyanosis. But if there is a murmur, presence of a murmur with severe cyanosis is an ominous sign. This is the most important indicator for the presence of cyanotic heart disease. So, especially if the baby has dysmorphic features suggestive of possibility, like if he has the features of a Down syndrome or features of a Noonan or features of other syndromes that may present with congenital heart disease, then in this case, you should suspect cyanotic heart disease, and you may do some tests to verify this. The hyperoxia test is an old test that has been established long time ago before the era of pulse oximetry, and basically it is dependent on obtaining blood gas samples at baseline and 10 minutes after applying 100% oxygen, and then checking the PaO2 in the blood gas. If the PaO2 rise more than 250, it's unlikely to be cyanotic heart disease. If it remains less than 150, then it is more likely to be cyanotic congenital heart disease. But this test should not be applied anymore today because we have a simpler test, which is the pulse oximetry. Pulse oximetry can recognize the critical, it does not differentiate simple cardiac lesion like a simple VSD or a simple pulmonary valve stenosis, mild or something like that, but it will differentiate whether the baby has tricuspid atresia, for example, or baby has coarctation of aorta. It will detect for you the major and critical congenital heart disease, because these can be still missed by the clinical examination. So the pulse oximetry can help to detect that. Nowadays, WHO advised to include this in the assessment of every single newborn exam. I know that majority of the big hospitals, like the Saudi German hospital, they apply the pulse oximetry screening for every single newborn baby before discharge. And basically, it is advised to be done in the second half of the first 24 hours by checking the pulse oximetry in the upper limb and the lower limb. And then the saturation should be more than 95% in all limbs. If there is a saturation of less than 95% in any of the limbs, or a difference of more than 3 in between upper and lower, then you should suspect it. There were multiple literatures and multiple studies that were done on big populations, like this study from UK that reviewed 20,000 newborn babies. And this was very sensitive in detecting, remember my words, critical congenital heart disease. So if the family get upset because you missed a ventricular septal defect, don't say that I did proper pulse oximetry. Pulse oximetry will detect pulmonary atresia, coarctation of aorta, those who will go home and collapse at home. So this differential saturation is important to check. As I mentioned, if there is an arch obstruction or if there is a coarctation in transposition, then you may have difference between the upper limb and the lower limb. So the guidelines, the American Academy of Pediatrics guideline, indicate that you should do it in the arm and 1 foot. The failed test is defined as oxygen saturation less than 95% or more than 3 digits between upper and lower. Like if the upper is 99 and the lower is 95, it is still 95. It is acceptable, but the difference is more than 3, this is failed. What do you do? Repeat 3 times at 3 different times, like at least 30 minutes between, and make sure that you use the proper probe, proper condition for the baby. If the if that continue to fail, then you should acquire an echocardiogram. In the investigation for assessment of a newborn baby with cyanosis, remember the baseline investigation like chest X-ray and ECG. These can be very helpful. Don't go for the echo or cardiac catheterization or CT or MRI. These are advanced and they can be reserved for the more difficult cases. The chest X-ray can be very helpful to differentiate because it may show you an immediate reason for the cyanosis, like this example. This is a baby who's intubated. The ET tube went into the right main bronchus and the baby has cyanosis. This is not congenital heart disease. This is another baby with congenital pneumonia, which is obvious from this chest X-ray with the patchy infiltrates. While this one, who's showing an abnormal boot-shaped heart with severe oligemia of the lung, this is a congenital or more likely to be a cyanotic congenital heart disease. This is another example for a possibility of cyanotic heart disease with a huge heart. This baby had an Epstein anomaly where they have a huge heart usually. These two babies are unlikely to be cardiac because of the significant changes in the lung. This one has a classical appearance of what is called egg on the side. If you look at the heart, it looks like an egg that is put on the side. You see, it is exactly like an egg on the side because of the narrow mediastinum here. The heart has a shape of an egg that is lying on its side. This is classical for transposition of great arteries. The other thing, if the baby has abnormality, like in the position of the heart or position of the stomach, then it is more likely to be a cyanotic heart disease. So after the chest X-ray, you may do an ECG and look at the rhythm and the axis, basically. Look at these two things, the rhythm and the axis. In the rhythm, if you have a normal sinus rhythm like this one, then it is unlikely to be a congenital heart disease. But look at this one. This one has a little bit heart rate on the lower side, and look at the P wave. You see the P wave in lead 2, lead 3, lead AVF. You see the P wave here, it is going down. In AVR, it is going up. The leads are connected properly, but these P waves are abnormally oriented. This baby had an abnormally structured heart. This is another baby with abnormal axis, which is a superior axis. All the leads are showing QRS that is negative. Superior axis is classical for babies with AV canal, actually. This is a classical ECG for a cyanotic newborn. If you see left axis deviation, you see lead 1 is positive, lead 3 and AVF are negative. They are not towards each other. Normally should be toward each other. These are away from each other. Then this is classical for tricuspid atresia, classical. You see in V1, usually we have dominant R wave. Here we have dominant S wave, not R wave. This is the classical appearance for this baby with this heart where the right ventricle is very small. There is no RV forces. Forces are mainly for the left ventricle. Always remember the differential diagnosis when you assess. Infection can be there, even if it is a cyanotic heart disease. So remember always to consider antibiotics in your initial management. You can stop the antibiotics if everything turned to be negative. Pulmonary pathology can also be concurrent with the cyanotic heart disease. Other examples is the metabolic disorder that may present in an emergency in a baby who's lethargic, pale. Endocrine emergency also can present in the newborn period. So how do we go if we are faced with a newborn baby? First, don't panic. Apply the methods that I just mentioned by the physical examination, the clinical assessment, the baseline ECG and chest X-ray, and then think about it. Is it more likely to be congenital heart disease or not? From the history, physical examination, ECG, and chest X-ray. And then what is the hemodynamics of this? Is there increased flow to the lung or decreased? Could this be ductus dependent? If there is a possibility that it is ductus dependent or the cyanosis is significant, like less than 70, you should start prostaglandin. Don't hesitate to start prostaglandin because you can stop it later on. Contact a cardiologist and then try to verify. These are the ominous signs that I want people to remember. If you have a central cyanosis with significant murmur, if you have failed pulse oximetry test or weak femoral pulses, or there is significant gradient between the upper limb and lower limb, or there is a respiratory distress with significant cardiomegaly, then in the first 4, consider prostaglandin. In the last one, you may not consider it. When you manage these babies, remember the important issues like the nutrition, avoid high FiO2 because it may induce closure of the ductus, Initial treatment may include diuretics and high PEEP. And always remember to treat infection, support the family, and early communication with the cardiologist. Referral to the cardiac centers is very important, and this is a nice picture for our King Abdulaziz Cardiac Center. Thank you very much.
Allah عليك يا دكتور فهد. Thank you very much for your two excellent presentations. I have just, there was one suggesting that if you suggest that the pediatrician will have an eco training and to be like BLS and like this. And I have another question. What is the normal difference between ECG for neonates and the children?
Very good. Both questions are excellent. The first question.
Then I have for you some.
Okay. The first question, now there is rising use of ultrasound, which is called point of care ultrasound. Now ultrasound is available in every emergency room, every ICU, neonatal intensive care units should have it as well. And there are courses for what is called point of care ultrasound. You don't need to know all the details, but you should be able to handle the probe, get initial views, and then there are some clues for major issues. I cannot go into the details here, but look for courses. There is a course that is done twice a year in our hospital in National Guard to teach non-cardiologists for these point of care ultrasound to detect heart problems. And not only to detect heart problem, but also to use that in the assessment of your management, like when you give fluids, if you are faced with a baby who's in shock, how much should I give? This point of care ultrasound can help you in your management. The other question about the differences, I think that is a detailed question, but basically there are some differences in the axis, because the newborn baby's axis is right axis deviation, while older children should have more towards the left axis. The T wave should be normal, except in V1 and V2, it is inverted in the newborn babies from day 7 until 7 years. Between 7 days and 7 years, the T wave becomes inverted in V1, V2. Before that and after that, it becomes upright. These are the two major differences.
Thank you so much. I have two parts or two questions. One, if I will use prostaglandin for a closing duct, which dose you recommend? The highest dose I will start, or a middle dose?
Very good question. Very good question, and the important question. I wish the pediatricians would remember this. If you are faced with a baby who is severely sick, like deeply cyanosed, or a baby that you suspect has coarctation and he's in shock, don't start with a small dose because it will take a long time. Start with the big dose and then you can wean. The most serious side effect for prostaglandin is apnea. If apnea happens, intubate and ventilate. And usually these sick babies, they are very sick. They require support for their airway from the beginning. So don't worry about starting a big dose that you may induce harm. No, you may induce harm by delaying the management. There is one exception for the prostaglandin, which is written in the books that people may think about it, which is the obstructed TABVD, which is a contraindication as written in Nielsen. My advice, start prostaglandin because you can stop it early. If the baby gets a problem from this TABVD, you can intubate and ventilate, okay? So don't delay management because you suspect that it might be obstructed TABVD and contraindication for prostaglandin.
Good. The second part, in newborns who will, with heart block, who will need pacemaker, when you will adjust the rate, you will take the lower rate or the middle or the upper, and will be this dynamic if this baby will be an infant and started to run and need more heart rate. This will be dynamic, or we have to adjust to more limits?
Yes, good question. Babies who require pacemaker, usually we put pacemaker at the lowest required rate because you don't want to waste the battery, because you can increase the heart rate, but you will waste the battery of the pacemaker. So you put it at the lowest required. And there are different types of pacing. There is what's called dual pacing and single ventricle pacing. And nowadays, most of the pacemakers, they have what's called rate-sensitive pacing. So if the baby start to have exercise or activity, then there is a sense the pacemaker may sense this and may pace high at a higher level according to that increased activity of the child.
Thank you so much for being with us. It was an honor to have you with us. Thank you.
Thank you again for the invitation and congratulations for this wonderful meeting.
Thank you. You can stop sharing.
Okay.
Our next speaker will be Dr. Abdullah Al-Shamrani. Dr. Abdullah Al-Shamrani is a pulmonology consultant in Prince Sultan Medical Military City. He is one of the eminent pulmonology doctors, and he is the chief of the pediatric pulmonology program. Dr. Abdullah will speak to us about two main topics. The first one is the pediatric chest X-ray interpretation. Then the second topic will be bronchiolitis and update. Thank you so much. You can start, Dr. Abdullah. Welcome you with us.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaikum assalam wa rahmatullah.
Thank you, Dr. Nabil, for this great introduction. And thank you for the invitation. And again, I'm repeating the same words for my colleague, Dr. Fahad, for congratulations for this outstanding conference for the 5th annual time. For me, I felt for maybe first time that I'm under pressure. You know why? Under pressure because I'm talking after Dr. Fahad Al-Habshan. Just give me a few seconds to speak about Fahad. Fahad, honest, he is really a pioneer one, and he is my preferred, not cardiologist, pediatrician, and human being. And if I kept saying, I would say 1 hour talking about Fahad will not be enough. I feel I'm like replacing Messi or replacing Cristiano or somebody else in the soccer field.
This is what I felt just last year. I was behind.
Today, inshallah, I will make it simple. I have two talks. One is the interpretation of chest X-ray. So I will take you for like a simple round in my pediatric pulmonary round. Just let me go for where is the next slide. Next slide, just 1 second, please. Yes, okay. So now the X-ray is really very common to be requested by pediatrician, and I felt it is also very common for all the pediatricians that they are missing some important finding here and there, and it should be the pediatrician should be aware about certain system, and they shouldn't miss certain important finding that could change the outcome of the child. So the outline today, I will go with some introduction and some remind my colleagues about some basic technical aspect. And I might go for common infection causes mainly radiologically. Then after that, I might go to some congenital abnormalities and cardiac cases and certain messages. If I have time, I might go with the real challenge cases. Unfortunately, this is very lengthy lecture, but I will be happy just to within 25 minutes to master or to give important message for the audience today. So main objective, I would like the audience to know certain basic rule for interpretation of chest X-ray and to be familiar about the systematic approach in the chest X-ray. Why? Because it's as I mentioned, it's commonly requested, and the failure of interpretation of the chest X-ray is a common. I appreciate that I'm a pulmonologist, I'm not radiologist, so also I have my own limitations, so I need some time as well to go and sit with the radiologist to discuss certain cases for second and appropriate interpretation. So in the past, we are using optimize the light and nowadays resolution and zooming. In the past, we are saying important again about the check the patient data and check the technical aspect. Okay, BA, AB, inspiratory, expiratory, exposure, rotation, right or left. But nowadays, I think maybe the North American approach is go to the A, B, C, D, E, F. Okay, which is each A, there is certain A that means, for example, assessment of quality, air or airway. Okay, so even the A, we can talk about 10 minutes about the assessment of quality and air and the airways. In the past, we used to say, please, you should have a system either from outside in or from in out. You need to localize the abnormalities. You need to know the clinical background about your patient, and you need to go with the radiologist because he is the most expert one. If I give you just, for example, a simple technical question in here, which is the most appropriate film in here? Is it film A or film B? I used to challenge the pediatrician, the resident, and most of the time they are choosing A. The A, what is the difference between A and B? Just keep in your mind, okay, I'm testing the projection. So I mean projection here, is it AB or BA? Okay, so what do you think? Just think about for 1 second or so. So A is the AB and the B is the BA. The standard is BA. Okay, posterior anterior, and the majority in pediatric we are using the AB. Now, how to differentiate between the two? Please keep have a look. If you're able to see the apex, are you able to see my pointer? Is it clear, the pointer? Not the pointer, the mouse?
Yes, clear.
So if that's fine, okay, because I don't have a pointer. See, if you are able to see the apex above the clavicle, this is BA. If you look to the breast shadow in here, this is likely, this is tenor stage 4. Actually, this is one of the real X-ray for my nurse in the clinic. She showed me her X-ray because she has some mild cough. And here, breast shadow, that means reflecting that this is an adolescent or cooperative, and this is the usual we are asking. And BA often, for example, patient sick and cooperative and young is not listening. Okay, and the third probably look to the scapula here. And number fourth, the gastric bubble. If you see a gastric bubble, that means this patient is standing. So this is the BA, this is the standard, but majority in the pediatric, you are seeing the AB. And if you see the, to make it short, if you see the clavicle above the apex of the lung, that means this is likely AB, okay? If you see the apex above the clavicle, this is BA. Now, this patient having bronchiolitis, and you see there is big differences between the two. Actually, these two X-rays comes in done in less than 5 minutes. So why it's important to know the basic? Because sometimes the expiratory film give you false positive cardiomegaly and gasless or opacity that could reflect, for example, pneumonia. But in reality, this is an expiratory film and the other one is inspiratory film. Again, some tricky point, for example, I'm testing the people. What do you think the exposure for this? What is the ideal film? Is it film A or B or C? Majority of the resident, most of the time they are seeing the picture C is the best. In reality, B is the standard in here. The why B is the standard? Because the film A is soft film, under penetration. Here I'm testing the penetration, the amount of radiation. So you are not able to see the vertebral bodies behind the sorry, I'm not able to see the vertebral bodies behind the cardiac shadow, while in here it is well demarcated. And ideally, you should see the vertebral bodies barely visualized behind the cardiac shadow. So B is the standard film, and C is over penetration, and A is under penetration. So all abnormalities that you are seeing in chest X-ray is ranged between radiolucent, which is the black, to radio-oblique is white, because of the radiation will go easily through the air and it will goes with difficulty through the unhit the bone or cardiac shadow. If you see this X-ray, I asked recently, what is the abnormality in this X-ray? Someone they say is stable sign, some the truncation of the trachea deviated to the right. In reality, the abnormality is this is a meant of it is comes from me. One day I have dextrocardia, and I sent the patient to confirm the dextrocardia, and when he found that the dextrocardia and the liver on the other side, so he returned the film and he showed me different film. So this is the exactly this is a mirror image. This is, if you look back to the case, 5 years with a cough, speech delay, that is speech delay, otitis media, and patient such will have sinusitis. This is Cartagena syndrome. Now, what is the abnormality in this X-ray? There is rotation and deviation of the trachea to the other side. So here I'm testing mainly for the rotation. And rotation usually simply we are saying, please look for the clavicle. If you are able to see the clavicle and the same level, this is rotation. But ideally, the radiologist, they would love to compare the distance between the medial aspect of the clavicle to the spinous process in left and right side. Then the shorter the rotated part. Okay. In here, I test many times again for this X-ray, and unfortunately, it was missed because all the resident most of the time they are focusing on the central part of the X-ray. Oh, so this patient has again deviation of the trachea. There is no big heart. Maybe someone said could be hepatomegaly. Well, what else? But if you look carefully, there is a big problems between and big differences between the soft tissue in the left and the right side, and the soft tissue in the left side is very large. This is patient has necrotizing fasciitis. This is maybe even I missed it myself because even pulmonologists could miss certain important findings because we are focusing on the center and we are forgetting the periphery. This child, he had a recent upper or sometime actually lower respiratory, whether viral pneumonia, COVID or not, but the father he told me there's something alarming in the X-ray. Then I said nothing. Then he sent it back to me and he alerted me, oh, there is abnormality if you see in the left axilla. This is calcified lymph node, even missed by the pulmonologist. Okay, I'm telling you, most of the time AB or B is enough, but sometimes you might get up to 10-15% added information from the lateral film, and the lateral film is important to confirm the retrocardiac infiltration, hyperinflation, or sometimes to know the dome of diaphragm here and there. Okay, I still we are not utilizing the decubitus film. If you having encounter patient with pleural fluid, with pleural effusion, okay, so I err to ask two things: what is the duration of illness, and do decubitus film. If the effusion in the left side, do lift decubitus film, then assess if then see if the pleural fluid is layered or not layered, I mean loculated. Then is it more than 1 centimeter or not? So if it is layered, that means this will be easy to be drained. If it's more than 1 centimeter, this is what need the intervention, whether at least diagnostic or sometimes diagnostic and therapeutic. Kids sometimes certain anatomy will change with time. If you see this child, he has really some abnormality here, but if you look carefully, this is a normal thymus. There is a clear blood vessel there, and the smooth surface of the thymus, and there is no pressure on the heart or in the mediastinum. And the same patient at 7 months, see the thymus is decreasing. So thymus decreases with age. But if I see, for example, the first X-ray or even the second X-ray at 7 years of age, oh, why did mediastinum? So T-cell lymphoma should be considered. So now the abnormality in the X-rays, we are going with zone, upper zone, middle zone, lower zone. Ideally, we are saying if it's hyperinflation more than 6 ribs anterior or 8 ribs posterior. Okay, so normally the inhalation could reach 6 ribs. So the first 2 ribs is the upper zone, third and fourth middle zone, and 5 and 6 is the lower zone. If you see now this X-ray, for example, there is opacity here or added density. Okay, but it's obscuring saluting the heart border. So saluting the heart border is right middle lobe. Right middle lobes have two segments, right middle and right lower. So this is definitely right middle lobe pneumonia. Okay, and sometimes if you see the is it obscuring the cardiac border, the phrenic border? Is there any bronchogram? Is there a deviation of the midline or trachea especially? Now, this is, if I go to the common infection, this is typical RSV bronchiolitis. There is hyperinflation and there is what prebronchial wall infiltrate. And this is the commonest type of the RSV bronchiolitis, actually. Okay, sometimes you might see normal, sometimes there is certain collapse with the severe cases. Okay, but if I say this patient is having 3 months in winter time, this is bronchiolitis. But if I say this patient has, for example, 3 years with recurrent wheezy chest, this is an asthma with exacerbation. This patient, for example, 6 years, presented with, for example, a week of a cough and malaise, low-grade temperature, and he often, the kids usually comes to us with not responding to augmentin or amoxil or sulfaroxime. This is a typical of the atypical pneumonia, which is, for example, the mycoplasma, and there is usually central infiltrate. If you look carefully for this patient, okay, there is obesity in the right middle zone, and then here in the left lower zone, here what could be ache. Sometimes this is we are seeing it in round pneumonia. Round pneumonia often kids less than 5 years. Staph, strep, influenza is the commonest, and just need antibiotics and will disappear with time. Now, I have a few slides now to differentiate between a collapse, consolidation, or effusion or mass. Okay, so this X-ray, now look to the trachea. Okay, the trachea is central. Okay, and there is obesity here in the right upper zone. Mainly, maybe the fissure is not clear, maybe a little bit distended here, maybe there is also some radiolucent, that means air bronchogram. Okay, and if you look carefully to the heart, looks fine. So this patient, if it is a collapse, I'm expecting the trachea will be deviated to the same side. So this patient is a consolidation with air bronchogram and the possibility of early ejaculation. So this patient is definitely pneumonia rather than a collapse. Okay, so now if I will go later for this is again pneumonia. If now this patient is what? This is obesity involving the right, middle, and lower zone, obscuring the cardiophrenic. Okay, so this is definitely involving the left lower and absent of what? Of air bronchogram. And so this patient is not likely just simple consolidation. And if you look carefully to the trachea ideally should be in the central of the spinous process, but the lower third deviated to the right side, but the trachea deviated to the other side. So this patient has definitely what? Pleural effusion and significant pleural effusion. So what to do next? Ask about duration of illness, ultrasound, or lateral decubitus, right? Lateral decubitus film, I think will be enough. Then you will decide later on if you proceed for what? For CT or not. This patient, for example, has obesity involving the whole right side, even the left middle zone, and this patient is having very large aspiration, and unfortunately this patient expired despite this case was published in Sudanese medical journal, despite I have cleared the patient 3 times from the OR with the therapeutic lung lavage. This patient, if you look carefully, there is obesity here, and sometimes the colleagues, the radiologists, they love collapse consolidation. That means 2 pathology in the same time. But if you look to the rib, the shape of the chest, it's abnormal. So it's narrowing the upper part and wider here. So this patient is likely to have neurological problem, for example, SMA. And the trachea is deviated more to the right side. So this patient is having likely what? More of a collapse. If you look sometime carefully, you see the space between the ribs in here is what is narrow compared to the right side. So this patient is likely as an aspiration pneumonia, and there is an underlying cause, potential neurology. So this patient, if you look carefully, this is a neonate actually. The trachea deviated to the other side, and also the heart is not really clear, but there is obesity involving the right upper zone, middle zone, and even majority of the right lower zone. And there is calcification. There is widening of the space between the ribs in here, okay? And also the dome of diaphragm usually in the higher side, a little bit higher in the right side due to the liver, but in here, the left is higher. So this patient has a mass, and this patient really has teratoma. If you look to the X-ray on the right side, you need the clinical history. What happened to the child? So if you look carefully, this is very important. This is a collapse. So this patient, the real problems is what's the problem? Is this collapse of the left-sided lung or hyperinflation of the right side? I told you the history is really very important. For example, if this patient is 18 months, he was well, then all of a sudden he started to have a cough. So this is likely foreign body impacted in the left main bronchus. If you look carefully, now where is the heart? Ideally, the heart is 2/3 in the left and 1/3 in the right side. Okay, so the heart totally deviated to the left side. Where is the trachea? We say the trachea should be in the spinous process unless the lower third deviated normally to the right side. Oh, so the trachea is deviated to the left side, and see the spine, the space between the ribs. Space between the ribs here is very narrow compared to the right side. And look for the diaphragm. The diaphragm is raised up in the left side. So I have here volume loss. So volume loss in here. This patient has total left-sided lung collapse, and if you look carefully, this patient has endobronchial, well, a cutoff sign is left main bronchus obstruction due to potential foreign body in the left main bronchus, and usually it is the second common site for the foreign body, as it's the commonest is the right side. The peanut, the watermelon seed is the usual causes. In this patient, diffusion with deviation to the trachea to the other side. Now, if you look to this, what is the abnormality in this X-ray? Patient has recent pneumonia. There is still some pre-bronchial wall infiltrate, but there is what? Rounded lucency in the right lower zone, and this is a typical of the pneumococele. Pneumococele can be commonest cause, usually strep, staph, Haemophilus influenza, and E. coli even. This patient has a lung abscess, and the abscess, lung abscess, there are two types of lung abscess, either primary or secondary. So patient was well perfect in the past. He had now there is obesity in because it's intraparenchymal with what free fluid level, and the wall had a big as what have thick wall cavity, which is different from the pneumococele, very thin wall. Okay, so now if the patient previously well, so this is likely primary lung abscess, and the commonest is strep or staph, and third generation cephalosporin, Clinda or Fanco is enough. Okay, but if you look to the other, if you look, for example, previous image or other image previously that the patient has some cavity, could be CCAM type 1 or bronchogenic cyst. Okay, now this patient, it's a real case, and this is one day I even challenged pulmonologists. They were not able to diagnose the case, but to the radiologist, when I showed the radiologist this X-ray, he told me your patient has invasive pulmonary aspergillosis. Also, why you said your patient has invasive pulmonary aspergillosis? If you look carefully, this patient is 17 years, has prolonged febrile neutropenia, and had obesity in the right and left main and lower zones. But if you look carefully, there is something here. Okay, so this is called what? Air crescent sign, air crescent sign. So air crescent sign usually for the febrile neutropenia will come with a focal or septic emboli. So there is focal infection in the X-ray. Then we'll go to the halo sign, more rounded shape. Then we'll go to the air crescent. So air crescent is a late manifestation of fungal infection, and it is really an angiophasic. What's next? This patient could have massive bleeding and could be bleeding to death. Malformation. This patient is 2 months. He presents with tachypnea and poor weight gain. So if you see, there is radiolucency in the left upper zone, and there is deviation of the trachea to the other side, and there is a radio-opaque in the left lower zone. So this is a typical of congenital lobar emphysema. Congenital lobar emphysema or overinflation is a common lung malformation. Often the approach here is conservative. Unless the patient has feeding, breathing, growth problem, then surgical intervention is recommended. This patient, even I just have published it in the maybe 2 months ago in the American case report. Okay, this patient is presented many times, 6 months, with to the ICU with recurrent respiratory problems, wheeze and cough. Okay, but if you look carefully now to the X-ray, there is bilateral hyperinflation, and where's on the left side. Okay, so why? What will happen? Sometimes we are saying could be Maploid syndrome or Swyer-James syndrome. No, if you look carefully, when we have done the CT, initially CT it was missed, okay, but when I have done the bronchoscopy, the carina should be sharp, but in here there is what dome shape of carina, and there is just one cyst. There is a cyst or a mass, 1 centimeter, making more pressure on the left main bronchus, and there is some pressure on the right main bronchus. So this is a typical position of the bronchogenic cyst. So we consult the surgeon and treated and cured and went home easily. This patient referred from me, and Dr. Tariq Al-Takhis, he is a respected pediatric surgeon. He have done the first case for him in King Fahd Medical City, if you remember this case. Came to us from Najran. If you see, there is large cavity here, okay, with fluid level. And also it's unusual, by the way, the lung abscess causing pressure on the airway, because lung abscess is intraparenchymal lung lesion, which is different from the pleural effusion, which is making pressure. So lung abscess is unusual to cause pressure, but sometimes the large lung abscess, it might cause pressure in here. Just imagine if this lung abscess communicated with the air, with the airway. So this bus where will do, the child might die very easily. So this patient treated with 4 weeks IV fluid in the King Fahd Medical City. Then we contacted Dr. Tariq, and when I looked to the all the X-rays, I found there is a cavity in here. So this patient has a typical of CCAM, congenital cystic adenomatoid malformation type 1. Why type 1? Because it is more than 2 centimeters. Type 2, numerous cysts less than 2 centimeters and often associated with another abnormalities. This patient, her name is Arwa, and she sent me one day her picture. Okay, so this patient, if you look carefully, those patients, even if they are asymptomatic, should be taken to the OR. There is multiple radiolucency and there is some cavitation here and there. And if you look to the CT, so there is multiple cystic change, and there is deviation to the heart. There is some collapse. There is some pressure on the mediastinum. So this patient is against congenital cystic adenomatoid malformation type 1. This is diaphragmatic hernia. Very clear on the left side. This is diaphragmatic ventilation on the right side. Okay, sometimes is it significant or not? Sometimes if it's more exceeding 30% symptomatic, you might need to call the surgeon for potential application. This patient is the Morgagni hernia. As you see it is in the central, and there is a GI or bowel with fluid and gases in between. If you look for this patient has what? This is very amine, okay, but looks like what? Like the X-ray. Important, because why I present it? Because if you look carefully for this patient who has failed to thrive with congenital anomalies, usually anal fistula problems or cardiac or vertebral. So this is factal disease, tracheoesophageal fistula, and the main problem for tracheoesophageal fistula later on is the reflux. Then number 2 is the stricture and the proximal pouch. Then later on, from the pulmonary aspect, the airway problems with tracheomalacia. So this patient is having what? Again, large lung abscess, and if there is lung abscess, is it primary or secondary? So this patient has secondary to sequestration. As you see, this patient has repeated admission due to lung abscess, but when you look carefully for the CT with contrast, there is feeding fizzle. So the lung abscess secondary to the sequestration. So you need to treat the sequestration as underlying cause. So maybe in here I will go for the cardiology. If you look, this patient is having a boot shape, a little bit oligemic. So this is likely tetralogy of Fallot, and you have a very nice film was shown today by Dr. Fahad for tetralogy of Fallot. This patient is the egg on size as shown by Dr. Fahad, okay, with congested lung. So this patient is having tetralogy of Fallot. I present this X-ray to the pediatric pulmonary fellow, and it was really a difficult case. But this is, if I show it to the cardiologist, they will get up the diagnosis very easily. This patient has right-sided lung hypoplasia, dextrocardia, and if you look carefully, this patient has what? Has coiling. So he had previous sequestration. Okay, So this patient, and there is what? The scimitar sign. So this patient has a scimitar syndrome. And scimitar could be two types, infantile and the non-infantile type. Infantile type could be severe enough, okay, to present like ischemia and very lethal condition, and the child will die from interruptible heart failure and pulmonary hypertension. You have seen the Epstein, and it was worse with Dr. Khalid, with Dr. Fahad, okay, and this patient with heart failure and potential chest infection, but sometimes, please, you might forget the periphery. And here the periphery is, there is an active, active rickets, okay, that been missed for this patient. So the challenge cases, do I have time, Dr. Nabil?
Actually, the time of the first presentation is ending now, but still, no, we like the presentation, so you can just continue, and we will give you more time.
Okay, thank you so much. So this is the airway. Sometimes the airway in pediatric is different. So there is buckling of the airway. So be careful. This could be normal finding. Sometimes in here, when I usually like this X-ray, and I put it many times for exam. And sometimes those going, for example, for the MRCP, oh, they will say pneumothorax. So pneumothorax is failed. Okay, so right side pneumothorax, bare failed. Okay, tension pneumothorax, 3 out of 5. Right-sided tension pneumothorax, secondary to central line insertion. This is the ideal answer. Okay, with so there is in here. This is the collapsed lung, and there is radiolucency in here, and there is no blood vessel. Okay, so this patient have significant right-sided pneumothorax with a collapsed right-sided lung due to the central line insertion. Sometimes they told me this is a cell sign. No, this is a cell sign, and there is blood vessel in here. Okay, so there is a normal bronchovascular marking, but in here there is no bronchovascular marking. This is what is this sign. This is called the spinnaker or wing sign. So this is pathognomic for pneumomediastinum. What to do for this patient? Oh, observe. Okay, hyperbaric oxygen. Okay, and hopefully it will resolve. This is a common X-ray in pediatric and shouldn't be missed. Okay, and this is the commonest type of X-ray and foreign body aspiration. So if the child, for example, toddler age or so, he presented with a sudden, so we need a high index of suspicion. Okay, because if patient hasn't observed to have a cough, I would say even a student should pick up the foreign body. But sometime, and the majority, 60% of the cases, the child, the event will not be observed or notified by the parent. So you need to look if there is asymmetry. So for example, asymmetry to auscultation, there is a localized wheeze, for example, here right-sided, okay, or the child is not a good responder to the Ventolin, or there is a marked abnormality between the hyperinflations. This patient has bilateral hyperinflation, worse on the right side, okay, so 40% of the foreign body will show hyperinflation on the affected side, and this is called check valve mechanism by Jackson classification. And the second type of foreign body and the X-ray radiology, total collapse. So that means the foreign body will be impacted in the affected bronchus. So the distal airway will be absorbed in distal part and will be ended with a collapse. So collapse could be 20% of the presentation of the foreign body, and the foreign body could be small enough. So bypass mechanism. So the air go in and out very easily. So we might see normal X-ray. And nowadays, after we starting to have the coin in the kingdom, we started to see radio-obic, and the radio-obic will be very easily. Okay, the treatment for such is ready diagnostic, is flexible, but we need rigid bronchoscopy and by colleague often the ENT. If you look carefully for this X-ray, oh, so there is some asymmetry and hyperlucency more in the left side. So this is the site of the foreign body. This is the case of foreign body aspiration. And sometimes this real case even was published a long time ago. This patient, it was initially referred to the cardiologist. Patient has BDA. They thought about migration of BDA device to the pulmonary artery, causing lung hypoplasia. Oh, when we have the echocardiography, it said no, normal. Okay, so when they consult the expert people like the pulmonologist, okay, so we thought about asymmetry, and when we have done the bronchoscopy, we found there is a missing foreign body in the left main bronchus. And this is, I told you, if you are lucky, you will have a radio obic, but if you encounter a radio obic, you need not an elective wait, because that case, it was in Ramadan, then I'm going to call the anesthetist and the wait till tomorrow. No, this is, we need to take the child NBO and arrange a visit to the OR. This patient was by a junior resident. He was happy by his rotation in the ICU. Okay, so what happened when he succeeded to intubate? He just kept advancing the 82 till it's reaching the right lower bronchus, and there's a total collapse of the left-sided lung. By the way, this patient has NG and NJ. NJ, how to differentiate between NG and NJ? NJ, it crossed the midline and take the C shape of the duodenum and back to the jejunum. So this is NJ, and this is sometimes I bring it as exam wise. So home message. Clinical information is important. You should have a system in your mind. You should have high resolution. Nowadays with high technology, it will help you to differentiate between certain pathologies, and you need expert, whether from pulmonologist or radiologist, and take second opinion if you are doubtful about your case. وجزاكم الله خير. Okay, if there is any question about the first lecture.
جزاك الله خير دكتور عبد الله. I have two questions here. Do you want to go to second question, then we take second lecture, then we take all in the end, or
yes,
I can give you?
That's fine. That's fine.
Okay, let us go to the second, then we can go on.
Bronchiolitis. The bronchiolitis, again, it's really very lengthy talk, but how many minutes remaining? Because I could summarize the message.
Take your time. I will give you 15 minutes.
Thank you so much. Thank you so much. So bronchiolitis, I present bronchiolitis many times, honest. Okay, starting I would say 2 decades. Okay, so I initially, when I left, the initial data comes from Cincinnati 97 about guidelines about bronchiolitis. So it comes to in my mind bronchiolitis guidelines. Then the initial guidelines in Clinical Medical City written by Dr. Saleh Al-Tamimi 2005 or 6. Then we update bronchiolitis guidelines. Then second guideline. Then the final guidelines by the Saudi national team called CIBRO. So I recommend the pediatrician to have a look for the CIBRO guidelines, and I will give you some update about the CIBRO guidelines. And just published maybe 3 years ago. Bronchiolitis is known a disease of debate. It is there is variation in the management of bronchiolitis. Okay, and long time ago, 56 years ago, and there is good data. Okay, there is huge data talking about bronchiolitis. Sometimes when I just go in literature, what is the update? Nothing. Okay, so despite I'm spending many effort looking for what is the update about management, I came like with a cock. 1963, oxygen and hydration is the main therapy of the bronchiolitis. And one more thing, keep in your mind, the kids, especially the high-risk group, 3 months, less than 3 months, when they are coming in the emergency with severe respiratory distress, the parent under tension and the family, the physician under tension. If it is bronchiolitis, what to do? Especially those junior, epinephrine is not recommended, Ventolin is not recommended. So what you will do, if the family in front of you and you are deciding sometime to admit, sometime to the ICU, it is the commonest, it's the leading cause of admission in the winter time, okay, even to the ICU. So bronchiolitis is the leading cause of admission anywhere in the northern hemisphere in the winter time, okay. Sometimes this is just a challenge, okay, challenge. What is the most effective therapy in bronchiolitis? Racemic, salbutamol, prednisolone, oxygen and hydration, all of the above and none of the above. Definitely, I'm expecting majority of the group will choose oxygen and hydration. Okay, if I didn't put the oxygen and hydration, none of the above. Okay, there's just one more thing here. If you go to the PubMed and just treatment of bronchiolitis, see how many data is around 10,000. Paper, okay, and again, if you have a crowded emergency, which one you will choose? For example, patient A who is 6 weeks, 2 days illness, He's reluctant to feed. He's tachypneic. His oxygen is the lower side. He's, I would say, febrile, and he has wheezy chest. And the other patient in the same emergency is 6 months, but he has 6 days as well. He's feeding still fair. He's tachypneic. He's statin 89. He's lower than the previous one. And he's febrile. He has some crackles. So which one, if you decide you have one bed, okay? So majority will go with what? A, B, A, B. The answer, ideal answer is A. So why A? Because this patient is high risk group, less than 3 months. Number 2 is still in the early course of the disease, 2 days illness. So I'm expecting this patient will get worse with time, while this patient often pass the critical window. So now what is the overview? I will go, I will overview about some background, utility of the investigation and management, and conclusion. Now, our guideline, the CEBRO, is the 9th respected international-wise guideline. So there is, for example, Nice, UK, France, whatever, there is Saudi guidelines, okay? So this is the Saudi guideline, okay? I have taken this statement from the GINA for the asthma to know that the bronchiolitis is a global public health problem. So you should know how to manage such cases. The team looking after the CEBRO from different specialty related to the bronchiolitis, from the ICU, pediatrician, pulmonologist, ID, emergency, and etc. Okay, and it will help you for diagnostic approach, for using the medication with evidence-based, indication for admission and discharge, and using the when to use the palivizumab, which is the Synagis. Because now back to the bronchiolitis. Bronchiolitis, by the definition itself, it is acute inflammation of the bronchiole. This is the definition. But in reality, it's a clinical condition. So there are different definition of the bronchiolitis. It's a clinical symptom. It's a constellation of clinical symptom, sign and symptom. That means cough, runny nose, and fever, and reluctant to feed, etc. Then the child will show lower respiratory manifestation, mainly wheeze, in kids less than 2 years. Oh, there is other group, they say it should be limited for the first lower respiratory tract infection. Sometimes a patient has 2 or 3 times in the first year. You will label the second time is bronchiolitis. Now even some researchers, they would like to cut the bronchiolitis from 2 years down to 1 year. Okay. Now, as I mentioned, it is an inflammation of the bronchiole, but in reality, the RSV, for example, it is observed from the nose down to the alveoli. So it's not limited. The infection is not limited to the bronchioles. Number 2, ideally first infection. So second infection is not bronchiolitis. And should be limited for less than 2 years. And one more thing to make it more complicated, the American, they would love wheezy chest is the usual presentation of bronchiolitis, but with the UK, the sign, no, crackles is predominant. So if bronchiolitis can present with wheeze or crackles or wheeze and crackles. Okay, so it is, as I mentioned, it's the commonest cause of admission. It is more in the rainy or colder month of the year. So in the past, we are saying the peak of the season is December and January, but the season in the kingdom here is starting from November to April. But what happened after the COVID? Now, even now, the seasonal after the era of the COVID, they say not the RSV is the commonest, could be, and even the peak could be September. And there is some data talking about there is a change in the pathogenesis of the bronchiolitis, and even in the peak of the season. So from now and then, we need more data talking in the country about which organism is the highest and which month is the highest. It is a common cause of hospitalization or even to visit to the ICU. Mortality is low, but could be higher in the developed countries and the high risk group, and it can cause a death. In the kingdom, in the commonest cause, definitely the RSV, but RSV is coming down. And now, what is the second commonest cause of bronchiolitis? There is a debate. Sometimes could be influenza, could be rhinovirus, could be human metapneumovirus, could be COVID. Maybe COVID now is the highest. Okay, so here there is a change, and sometimes co-infection, it might be having up to 20 to 30% of the cases. Before the era of the COVID, still the RSV is the commonest. It is single-stranded RNA. After the era of the COVID, we don't know, honest. We need more data talking about this. So as we mentioned, why we'd like to know about the RSV, because it's single-stranded RNA, has two main glycoprotein, and the G protein, it is important because it will prevent the penetration of the organism to the cells if you give the antibodies like the palbociclib. RSV, just see this normal lung. The right side is what is infected with RSV. If you see now, there is mucus plug, and there is inflammatory cells, and there is hypertrophied muscles. So that's why you see this mucus plug could work like foreign body. So why? Because this mucus plug, the air can go beside it and end with hyperinflation during because the inspiration is an active process. But sometimes if this mucus plug is full, it will end with a collapse. And if ending with a collapse, and the commonest collapse is right upper zone, then basal area. And that is the cases which are really severe. One important message when you encountered bronchiolitis, ask about duration of illness. The worst usually day 3 to 5. And the child could cough up to 4 weeks. And after 4 weeks, he will expected to have a second like upper respiratory tract event. Okay, keep in your mind, in high risk group, less than 3 months, presentation of in the past called apnea or ALT or PRO could be 20% of the cases. So majority of the kids, they will start resolve by the end of the first week, but they could cough up to 4 weeks. And again, third of bronchiolitis will go on the line of asthma. Again, this is an important message, and never encounter pediatric bronchiolitis case unless you ask yourself, is this patient from the high risk group or non-high risk group? What is the mean of high risk group? Less than 3 months, prematurity, congenital disease, immunodeficiency, Down, CF, and etc. Okay, now the utility investigation. Nowadays, rapid antigenic detection, okay, and the yield is very high. In the past, we are using the direct fluorescent antibodies, looking for the apple appearance under microscopy, and it is very effective. Culture and PCR, culture we are not using it. PCR is really very helpful. This is, as I told you, this is the commonest type of X-ray in bronchiolitis. And this is when we see the collapse often in the right upper lobe, this is suggesting the patient is sick and he might go to the X-ray. X-ray should not be done routine. It should be limited with a severe respiratory distress. If the patient you are suspecting to go to the ICU, or you are suspecting a complication like an air leak. But if you do an X-ray, majority, 50%, you will say there is lung infiltration. And you will end with at least 50% with unnecessarily antibiotics. And antibiotics is still very common to be used in bronchiolitis and could reach 90% literature. So message, limit the X-rays in bronchiolitis unless there is a certain question in your mind. Again, the CBC shouldn't be done routine unless febrile or atypical presentation. Criteria of admission, patient distressed, poor oral intake, query septic, uncertain about diagnosis, or you have psychosocial problems. Discharging criteria, okay? Discharging criteria, feeding well, at least 80%. Patient is not tachypneic. Patient satting, at least 90, no psychosocial problems. Management, as we mentioned, very important, close observation, oxygen and hydration. Oxygen, by the way, there is a big debate. Smahli, Nabil, I know that maybe I'm approaching my end of the time. Oxygen.
No, you take your time.
Thank you so much.
This is a very important.
Thank you so much.
Subject.
Why oxygen here is very debate area. Okay, if you look to the American Academy, they said accepted 90. But if in reality, if patient comes to you in the emergency, 2 days illness, starting 90, no, this patient needs admission. But I accept 90. Okay, after 3 days, 4 days admission, case bronchiolitis, he's feeding well, he's not febrile, and he's ready to go. So why? SAT 90 means BO2 60. So patient is not hypoxia. So definition of hypoxemia, BO2 below 60. So I will accept 90 for discharge, but I'm not accepting 90 on admission. Okay, so one more thing. If patient encounter to you in the emergency, starting 90 and below, need admission. More than 94, likely to go home. 91 to 94, observe and see 1 hour, 2 hours, up to 4 hours in the emergency, then decide. Okay, take now for your patient who already admitted to the hospital, bronchiolitis, and he is requiring oxygen. When you discharge this patient, ideally, minimally should be oxygen should be discontinued at least 12 hours prior to discharge. Okay, because sometimes this comes to for in the private, is it financial, accepted, not accepted, patient as well. So sometime nowadays I'm going for minimum 6 months if the family having problem with the insurance and the child is off oxygen. So I would say, please, if the child is meeting the criteria of this child, not febrile, feeling well, okay, and he's not tachypneic, and certain 60, 90, at least for minimum of 6 hours, I will discharge him with a follow-up with the general pediatrician. For the feeding, just look for the if patient has mild respiratory distress, you can continue the oral, moderate OGT, for example, severe IV fluid. Okay. There is no role for the for aggressive CBT. Just you need gentle suctioning before feed and inhalation. There is no role for aggressive CBT for the RSV bronchiolitis. Be careful about transmission of the RSV. It is highly contagious, okay, especially for an area closed unit like the big NICU like Saudi Germany hospital. In here, you need, if you encounter patient with RSV, you need the personal protective equipment, because the RSV is contaminating the area as far as 20 feet. That means 6 meters at least. So if you encounter the area of RSV, so starting from the knob of the door, so this area is contaminated with RSV, down to the stethoscope, to the pillow, to whatever in the room. Okay, so you should wear personal protective equipment. So which one to start, gown or gloves? So this is an important for prevention, and for pediatrician they should be what to start to wear first and what to leave after. So the RSV, they should be isolated. Hand washing is very important. Decreasing the improvement in the hand washing could prevent 50% of spread of the RSV bronchiolitis. There is no rule for bronchiolitis, but for bronchodilator. But in here we are against the American Academy of Pediatrics. Why? Because asthma is very common here. And to make it the summary in 4 points. Bronchodilator is an option. It is case by case. Continue if there is improvement. When to continue if there is improvement. Sometimes I give bronchodilator once, twice, 3 times. 1 time is not enough to judge is this patient good responder to bronchodilator or not. And there is modest benefit of racemic epinephrine to compare to the fentanyl. In my real practice, I will ask: is the child atopic? Is there a strong family history of asthma? Then I will give fentanyl. If nothing at all, I will give racemic epinephrine. The racemic epinephrine, I will give it in hypertonic saline, 3%. Okay, then I will assess. If the patient is a good responder, continue. If the patient is not a good responder, you need to stop. Steroid. If patient is a good responder to the bronchodilator, he might be a candidate for a systemic steroid. Okay, if you look carefully to the guidelines or the literatures, there is no evidence. Asthma is very common in the kingdom. Okay, so if patient showing, for example, a good response to bronchodilator, but he is still sick and hypoxic, I will give him benefit of steroid, honest. Okay, ribavirin is not recommended. Antibiotic is not recommended. okay, and the risk of secondary bacterial infection is 1 to 2%, which is different from the ICU. And the commonest cause of infection in the bronchiolitis either UTI or otitis media. So antibiotics consider for atypical cases like sick patient who required ICU or respiratory failure, or there is a genuine otitis media, or you have positive indices suggesting UTI. So antibiotics, we need to stop it because, as I mentioned, if you look back to the literature, up to sometime 99% of the cases they have what they are using, and C is 98%. Or there is no contamination of secondary bacteria. If you look carefully for the urine and otitis media and your patient is not septic, there is no indication of antibiotics. This slide, I would say, the most beneficial for bronchiolitis. Hypertonic saline is proved to be effective 3% or 5% for the admitted cases. For the admitted cases, it could decrease the length of admission by 25% of the cases, and the idea comes from the CF group. Helix is recommended for certain cases in the ICU, and these are the recommendations about our guidelines. Okay, for example, bronchodilator is an option, epinephrine option. Okay, steroid not recommended, but I'm telling you, okay, because asthma is a common in the country. If your patient is still sick and showing good response to bronchodilator, you might give. This is an area of debate, as I mentioned. You might see some people saying, no, Dr. Shamrani, I have the evidence of American Academy. I agree. This is a disease of debate. I'm talking about after 20 years of experience in pediatric. So Cipro is not all the anticholinergic, antihistamine, Dornase alpha, montelukast, azithromycin is not recommended. There is a good data about CPAP, high flow nasal cannula for the sick patient. RSV is not indicated, and bevacizumab is really very effective, and there is a protocol for that. It is costly, but it's really very effective. One day, I was the founder of the RSV program in King Medical City. One day, 6 years data, the effectiveness is 98, zero side effect. Okay, but it's really very costly. Each season covering 125, it's about 2 million riyal. Nowadays, there is some data talking about vitamin D in bronchiolitis could be associated with the severity. And nowadays, some data in the after the year of the COVID that alerting the people now the season is different for the peak of bronchiolitis, and also the organism. For example, in here it is rhino is the commonest cause of bronchiolitis. So in the summary, bronchiolitis is a heterogeneous condition, okay, with heterogeneous response. There is still debate. You need to look for an evidence base for your patient. Promising hypertonic saline, promising bevacizumab, really. Okay, there is guidelines. You need to utilize it, and we need to activate or implement these guidelines. We need to look for the bronchiolitis after the year of COVID, and I recommend to use the Cipro. Jazakumullah khair. Thank you so much, Dr. Nabil, and I will be happy to have any question, please.
Thank you so much, Dr. Abdullah, for your wonderful presentations. I have some questions. I will go to them. The first one, how to differentiate between right middle lobe and right posterior lobe pneumonia in X-ray?
Thank you so much, Dr. Nabil. Right middle lobe. Right middle lobe has two segments. Right medial segment and lateral segment. Okay, so if through the X-ray, if you see saluting the cardiac border, so this patient is likely to have definitely right middle lobe, 100% the medial segment. The other segment, which posterior, we say
right posterior.
Right posterior. So often the obesity in the right lower zone. If the patient has like normal inspiratory film 6 ribs, so I'm expecting the obesity not in the upper zone, maybe in the middle zone, but likely in the right lower zone, but not obscuring the heart, and no association with no deviation of the trachea to the same site or the heart to the same site, and the diaphragm remain in the expected time in the place, plus some air bronchogram. So I would say it could be difficult, but as suggestions, but definitely how to look at either CT or bronchoscopy. X-ray is tough, but I will tell you, is it right middle loop or not? This is the thing that I will be sure about it.
Okay. Second question for Dr. Lujain Shalabi. What's NGA? حضرتك قلت
nasojejunal tube. Okay. So sometimes this nasojejunal tube, the intensively like it because it will pass the stomach to the pylorus, to the duodenum, to the jejunum to prevent aspiration for sedated patient. So it is recommended for the paralyzed patient, for example, to avoid a patient
maybe because you wrote NGA, not NGT. That's why she thought that it's another thing. A tube,
yeah,
nasojejunal tube, so NGT.
NGT, yeah, okay.
Yes. Type. There's another question from Dr. Marwa Saad. Is there a role for ipratropium bromide nebulization to dry the copious secretions in bronchiolitis?
Again, this is a very intelligent questions because pathophysiology, the ipratropium bromide will decrease the secretion, but evidence said no. Okay, I'm talking about the majority of the guidelines, but physiologically, maybe yes. So I'm honest, no. It is just the recommended for the hydration therapy, gentle suctioning to the tip of the nose, not even deep. Okay, because those kids, the minimal handling is really important. So I see, it's good for the asthma patient, but not good for the bronchiolitis.
Okay, I want also to ask if there is no racemic epinephrine, can we replace it by regular epinephrine?
Yes, but I think the dose may be 5 times. Okay, if you look carefully, the potency.
Okay.
But I like in general because the Ventolin is available. If the family has, for example, asthma or the child has atopic, why not to give Ventolin by default? Because asthma in the kingdom 23%. So there is a quarter response, okay, for your patient with any bronchodilator. Okay, this is one message. Number 2, if the child is atopic, so there is again 25% chance extra that so you could reach 50% that your patient could respond to the bronchodilator. So I have no threshold to start the bronchodilator.
Okay, last question. How many chest X-ray we can do per year?
والله سؤال وجيه. Honest, I don't know because sometimes the CT, one CT could be reaching 200, the high resolution.
200 X-ray, yes.
Okay. So maybe you will harm your patient with one CT rather than 200 X-rays. So message, you should be carefully use it if needed. Okay.
And limit as much as you can.
Yeah, no, not as you can, but definitely there is certain limit. Sometimes the radiation, penetration, over penetration. Okay, so each you don't know how many radiation given for, but definitely there is certain limit that I cannot remember or I'm not aware about it. Maybe radiologist can help, and that's why I say radiologists need it.
Okay. Thank you so much, Dr. Abdallah, and we were honored to have you with us, and we hope to have you for many lectures other than our symposium.
شكرا لك وشكرا للفريق الطبي حقك ونبارك لكم هذا النجاح الباهر واسال الله ان يعلي شانكم وفخور ان اكون بينكم. شكرا جزيلا لكم.
شكرا. مع السلامه. You can stop sharing this. You can stop sharing it. Yes, okay. Our next speaker will be Dr. Khalid Al-Ghamdi. Dr. Khalid Al-Ghamdi is a consultant pediatric GIT in Security Forces Hospital in Riyadh. Dr. Khalid is one of our eminent GIT consultant for endoscopy and all GIT problems and diseases. He has a very good reputation in Riyadh. Dr. Khalid will give us 2 lectures. The first one will be GERD in children. The second one will be acute liver failure in pediatrics. You can start, Dr. Khalid. Welcome you, and we are happy to have you with us. You can share your presentation.
Thank you. I'm just trying to share, but the icon here, it doesn't allow me.
Why?
Share screen.
You went from the link we sent you an email as a panelist?
Yes.
I think you will have share screen.
Okay, so I will try again.
Try again, okay.
Just to log out and log in again.
Okay. Dr. Aghda, you are with us, yes?
Yes, I'm here.
طيب, in case Dr. Al-Ghamdi will have a technical problem, I think you can start until he will finish his problem, but I will wait for him when he will look again.
No problem.
Your presentation is ready.
Yes.
Okay, so we'll just wait for him. If he still has problems, so we'll give a chance for you to start and we'll wait for him. Thank you. دكتور خالد, لو المشكلة لسه ما زالت عندك ممكن دكتورة رغد تبدأ على ما حضرتك تحل المشكلة.
Who I just join again. Do you make me a host or co-host?
I think you don't. You are panelist. You will see it down in the screen. Share screen.
Okay, sorry. So yeah, now is.
You don't need to be a host.
Sure.
يعني لو حضرتك الماوس هيطلع عندك شير سكرين تحت.
Sure. تمام.
ايوه. انت
Is it
لسه.
okay? Is it okay now?
هي الشاشة بتاعتك موجودة بس انت ما انتش لسه في
Sure.
الزوم. ايوه كده. اتس اوكي. لا ده افتح البرزنتيشن بقى. يس.
Yeah. Sorry.
فول سكرين بقى.
Okay.
You can start.
Sorry for delay. I was thinking to join through the other window, not the.
No, this is okay for us. This is okay for us.
So thank you very much for the invitation. It's my pleasure to be with you with this great symposiums yearly, keeping it up all the time. So with your big effort actually is, so thanks for the organizing committee, for you, Dr. Nabil. I'm so happy to be with you today. Hopefully we'll add something to the audience. If not really a good thing, so sorry, but I will try my best.
Welcome, Dr. Khaled.
So gastroesophageal reflux disease. The big things in pediatric GI, we have a lot of consultation, and I think pediatric gastro esophageal reflux disease is overdiagnosed by non-GI pediatrician, and to be honest, underdiagnosed by the pediatric GI specialist. So always there is the conflict between the GI and other, is it pediatric gastroesophageal reflux or not? However, because we'll see in coming few minutes, you will know where is the difficulty and why it's challenging. So definition, gastroesophageal reflux disease is a normal physiological phenomenon. For everybody, if you are sitting on heavy, fatty meal, you start to eat, you drink after that some of soft drinks, you will burp. And once you burp, the relaxation of the lower esophageal sphincters will happen, allowing for some of the gastric content going up. And with your normal physiological esophageal peristalsis, that will be cleared very quick. So this is normal. Babies also having the same, children also having the same. So GER, or gastroesophageal reflux, is the passage of gastric content into the esophagus. With or without regurgitation, with or without vomiting, that is something we'll talk about. So this is normal. When it will be abnormal, when it's causing problems for you, when it's troublesome symptoms or leading to complication. At this point only, we'll call it GERD. At this point only, we'll complete the name. We'll call it gastroesophageal reflux disease. But before, without any troublesome symptoms, without any complication, we'll not call it a disease. We will call it just a reflux. So another thing's important in the definition, is it vomiting or regurgitation? Because you will see a lot of moms coming to your clinic complain of this issue. The first question, is it regurgitation or vomiting? And you should know what is the difference. Both are leading to retrograde movement of gastric content to the esophagus. The only difference here, if it is only spilled over the cheeks, the chin, this is just regurgitation. This is normal. And you shouldn't be worried about it, even if it is very frequent. But if it is pushing it, that is the vomiting. So in another terminology, regurgitation, effortless, while the vomiting is forceful. So once there is forceful, that means the baby will push it. How to differentiate between that and projectile, this is another thing. It is tough sometimes because this is subjective description. So don't take the projectile as just pushing. Projectile is like fountain, which is very, very strong push. So if it is regurgitation, don't worry. If the baby otherwise normal, just reassure. This is one of the old studies which looking for the regurgitation in babies. And you see the most of the regurgitation happened between 3 and 6 months. And you see up to more than 60% of babies, they regurgitate between 1 or 3. And some of them more than that even. Up to 20%, more than 4 times per day, which is, that's why we call it normal. So why it's normal? As you see, for the gastroesophageal reflux, usually you need the sphincters, and the sphincters is not working alone. There is a lot of anatomical issues here helping to tight the reflux or the sphincters in the lower sphincters. The diaphragm, the lower part of the esophagus, which is abdominal, the ligament, the valve, all work together to make strong sphincters, which is here will be less or weaker in the small babies or in children. And once they grow up, this will get more and more strong. As a just example, the lower part of the esophagus, which we call it abdominal esophageal part, it is very, very short in babies. So they have some defect still for their normal physiological development, which will come later on. You just need to be patient with them. Okay, so why we are accepting vomiting and regurgitation in babies? While you are not accepting that in adults. If you see, if you are eating and your stomach full of food and you regurgitate or whatever, there is some reflux because of burping, let us this contents go up to like 5-10 cm, still in the lower esophagus, because the length of your esophagus at least 35 centimeters, because the diameter of your esophagus is not allowing for going more and more proximal, and because of the gravity helping to clear that very quickly. Babies, they don't have that. They are on the supine position most of the time, so the gravity is not helping. Their esophagus is very short, so even little amount, which is just 10 cm, may will actually trigger the center and causing vomiting and regurgitation. Once it is in their throat, they will just bring it out. And also the diameter. So as a physicist, the very narrow straw, if you put it in a cup, it will go up, not like a wider one. So this is why vomiting and regurgitation in babies, otherwise healthy, it's normal. What is the pathological factors behind this? Mechanism of GER or reflux, not disease. Normally, we have transit relaxation of our lower esophageal sphincters. If there is increase in the intra-abdominal pressure, whatever the cause, like asthma patient, distress patient, full of feet, whatever, reduce the esophageal capacity also, gastric compliance, delayed gastric emptying, all this will lead to more reflux. If there is defect in the esophagus to tolerate this reflux, that may lead to some symptoms. And if there is a problems with airway protection, that may lead to some of the complication like apnea. Symptoms. So how they present? Babies, recurrent vomiting and regurgitation, that is the complaint. But as I said, most of the time is just, we call it reflux, not a disease. So really, we don't consider that important symptoms because this is not specific here and not sensitive to diagnose as a disease. However, if there is hematemesis, that is something else, and you will hear about it in next slide. So what other symptoms? This is other symptom they can present with it. Irritability, not sleeping well, it's all the times is fuzzy, and feeding refusal, failure to thrive, or dystonic neck posturing, or Sandifer syndrome. Other things in babies, wheezing, cough, stridor, hoarseness, all these symptoms will lead to thinking of GERD. While in older children, they can present with some of the previous one, but also if vomiting or regurgitation here, we consider it more important than the small babies, as I described before. Heartburn or chest pain, they can describe for those above 8 years. It will be typically like adult symptoms, epigastric pain, dysphagia, or adenophagia. So that's the symptoms. What's the signs? A lot. From the respiratory point of view, apnea, asthma, recurrent pneumonia, you will find maybe recurrent otitis media not explained, dental erosions not explained, anemia, and once they get complicated, they may present with anemia, with esophagitis symptoms like hematemesis, with esophageal stricture like dysphagia, or even Barrett's esophagus. So what you need just to make sure what is the symptoms you have. and then go after alarming sign, which we call it red flag symptoms. Check if there is weight loss. This is not a typical for GERD. Usually they don't grow well, but they don't lose weight unless very severe one. So once there is weight loss, you need to investigate more. Lethargy, fever, excessive irritability, or dysuria, it may be a sign of infection, and especially hidden infection like UTI. Onset of these problems, if it started after age of 6 months, that's not the typical for reflux. So reflux for babies or infants started from the birth or from the first month, then it's getting better, not later. And persistent or increasing after the age of 1 or 18 months, which is here the age we're expecting the reflux to improve and resolved. So if it is increasing or still persist, then you have to investigate more and more. Look for any sign of CNS, like bulging fontanelle, increase in the head circumference, seizures, macro or microcephaly. This is maybe the hint for increased intracranial pressure, which can cause vomiting. Make sure it is not persistent projectile vomiting or nocturnal vomiting, which is again other signs for increased intracranial pressure, or not bilious vomiting, which will lead you to suspicious of intestinal obstruction, complete or incomplete obstruction. Hematemesis, which may lead you to think about ulcers, could be just related to the GERD or not. Make sure there is no chronic diarrhea or rectal bleeding, which will give you a hint. It could be this is allergy-induced enterocolitis. Make sure there is no abdominal distension, which will maybe due to some GI dysmotility. That is the important signs you need to make sure about it in your clinic. If nothing from all of those with otherwise healthy baby, that is reassuring. So you have a baby who have suspicious of GERD in the clinic, history, physical examination were fine, and you didn't find any alarming signs. If there is alarming sign, you need to look for the cause and treat accordingly. But if there is nothing, then the first step, just avoid overfeeding. Believe me, most of these babies, they mother bring a baby who's 3 kg to the clinic, complaining of the vomiting and not feeding well, and his weight is 7 kg. So that doesn't make sense. So just go over with the mother. Sorry, you hear me, right?
Yes.
Okay, so it's just to make sure with the Zoom, you lose the contact. Always.
No. It's okay. And what you are saying is totally true. All mothers want the baby to be
So the first things, just avoid overfeed. Even if some babies, they tolerate overfeed, but not all the babies. So avoid overfeed, try to thicken the formula, the feeds, and if the mother and breastfeed, don't change, continue on breastfeed. Improve, just continue the same management, which is okay. Not improved, you can consider trial of hydrolyzed formula, because always we cannot differentiate easily between GERD and cow's milk protein allergy. They can present with just persistent vomiting, the cow's milk protein allergy. So give a trial of 2 weeks. If not improved, then take it out from your mind. This is not a cow's milk protein allergy, and go back and concentrate on treating GERD. If they improve, then this is cow's milk, and just try to reintroduce later on what we call it challenging and see. If not improved, then that's the time to refer to GI. If the GI not available, then it's okay to give a trial of 4 to 8 weeks of acid suppression and see. If you can wean it later on, that's fine. If not, then you can revisit your differential diagnosis and look for if you are missing anything. What about children. For older children, again, history exam, any alarming sign. If there is, then look for the cause. If not, then again, lifestyle and dietary education. If that's work, that's enough. If not working, you can give acid suppression for 4 to 8 weeks. If that's help, then try to wean. If not helping, then you need to refer to GI. If you cannot even wean, then you have to refer to GI. In the GI, what we do, usually with those with persistent BBI dependent or not helping them, we go for endoscopy to make sure about the finding. If we find erosions or other mimicking diagnoses like eosinophilic esophagitis, we treat accordingly. And if there is nothing, then we consider impedance study. While if there is no erosion, but the response to BBI, we give more prolonged period on BBI and try to wean it later on. For the impedance, if they have abnormal acid exposure, this is what we call it non-erosive reflux disease. If the normal acid exposure normal, but they are symptomatic, then this is reflux hypersensitivity. If negative symptoms correlation, then this is functional heartburn. So that is the how to approach. Remember this slide. There is no single gold standard investigation to diagnose GERD in infant or children. Nothing. Barium, we do barium all the time, just to rule out, but not to diagnose GERD. So it's not specific, not sensitive. Reflux events were detected in 50% who went for radiology imaging regardless of the symptoms. So even if you send a normal baby, you may find there is a reflux. It doesn't mean he has a disease, as I said. For just remember, BH, we need 24 hours. And during this 24 hours, even if happened reflux 30 times, still we don't say GERD. We say reflux only. So how come with one single barium, with one attacks of reflux, even if it is reached to the proximal, we will label as a disease? We cannot. So the barium, we do it for just to rule out anatomical issues. So what's the indication? If I have a normal baby's typical reflux, then I will not do it. But if there is alarming sign, if the symptoms is very intense, not responsive to traditional therapies, then that's the time I will go for barium, looking for something like that, which is hiatus hernia, which is this small baby. Still, you can see congenital hiatus hernia, which is the cause for reflux, or differentiate from other issues like achalasia here, or pyloric stenosis in small babies, even though they will not present typical. Some of them, they have just mild pyloric stenosis. So to rule out anatomical abnormalities, which is treatable. Otherwise, we'll just keep the same approach. Other things always keep it in your mind is the modified barium or fluoroscopic swallow study. This is very important to differentiate between GERD and the swallowing in coordination. There is neither the clinical history nor observed feeding session can accurately predict which patient have oropharyngeal dysphagia versus GERD. So that is very important, especially for those with recurrent chest issue. What about nuclear? Nuclear scan, we, again, the same idea like the barium. You cannot depend on it, even if it showed reflux like this one. Okay, there is reflux, but is there a disease? That's the questions. However, we need it for two indications mainly. If I want to make sure the recurrent chest problems not due to aspiration, like here in the other one, you can see the dyes is in the left lungs here, which indicate there is something going to the lungs from the reflux, or to assess the gastric motility, to delay or to exclude the gastric delayed emptying. Ultrasound, not very helpful, only to rule out other causes, not to diagnose GERD. Endoscopy, again, not to diagnose GERD. And you see in patient with troublesome symptoms, which they are symptomatic, clearly they have GERD, and still to find something microscopic esophagitis is up to 80% only. So it's still 20% on those very clearly GERD patient can be missed. So it's not very helpful. And especially for those with extraesophageal symptoms, the finding of esophagitis were found only in 32%. What about the indication? Again, some of alarming symptoms like hematemesis definitely need to go for endoscopy. For detective complication of GERD, like if you are suspecting stricture or esophagitis, or condition that predisposed to GERD, like hiatus hernia, not clear in the barium, you are still questioning that, or other condition mimicking GERD, like eosinophilic esophagitis. There is other biomarker. They are not really sensitive, not specific. The best one of them is salivary pepsin, but they found it in the mouth even on third of the normal patients. So still not really good one. Manometry, esophageal manometry, again, it's not to diagnose GERD, only if I want to evaluate the esophageal motility. That is where it will help. So we can go back to a simple things, which is trial. Give trial of proton pump inhibitor and see. That is yes, in adults, 1 to 2 weeks, they give it and see that after that, if they improve, then that is GERD. In infants, no, it's not helpful, not recommended. And do you know why? Because most of the reflux in infant is not acidic. So BBIs will not help. But for older children, yes, it could. For the expert people recommend in children 4 to 8 weeks trial. If the symptoms improve, then that may support the GERD diagnosis. There is insufficient evidence exists to support the short trial of BBI for diagnostic of extraesophageal reflux symptoms. So it's not for those asthma, recurrent pneumonia, or whatever. No, it is not the best. What about pH monitor? pH monitor, it is good to detect acidic reflux, to determine the association between the acidic reflux and symptoms, and to assess the response to the acid suppression medication. But the limitation cannot detect non-acidic reflux, which is the most common in babies and infants. So pH is good for older children. And we don't have a gold standard normal values on pediatric yet because of the difficulty to do it. So we have the pH with the probe, like that one, or the Bravo, which is just putting it down by endoscopy. And that's something they do it more in adults. And this is the normal, maybe that's our skip. So what is the gold or the best tools we have? It is impedance, which is both. Here, you see this is pH, like the previous old one. But plus of that, there is a sensors for the pressure. So once anything going up, it will be detected. Acidic or non-acidic? Acidic will be detected by the pH, non-acidic will be detected by changing in the pressure. And they are coming from down up to here to the proximal. So we can know even where it reach the reflux when it goes up. And we can differentiate, is it a swallow or reflux? Because if it started up and go down, that's swallow. While if it is reflux, then it will go from down to up. So it is very good tools. And it's the best actually, but it's still not 100% to diagnose GERD. So it is very good. It detects the brief one of reflux and useful for studying the respiratory symptoms and GERD. Limitation, it is not available everywhere. Normal value in pediatric is still not there. There is some trial, but still we don't have. We depend on the symptoms, correlate the symptoms with the results. And unfortunately, most of the time, the symptoms, it's not happen frequently. Like they refer a baby with apnea, then I put this impedance down and will spend all the 24 hours without even single apnea. So we cannot. So that is, it's happened. And even if there is apnea, sometimes the parent, they just miss it. They don't know. So there is a lot of issues make it difficult. So what about management is depend on that. Sorry, how many minutes
You have for this presentation 2 minutes, but you still have the second presentation.
Sure. So I'll just make it very quick. For infant with recurrent vomiting, the main things, don't consider pharmacotherapy. This is normal, they will pass it. So just make sure there is no alarming symptoms, reassure. You may try hypoallergic formula, you may try thickened formula, and some change in the life or the lifestyle. For those with poor weight gain, you have to go for further investigation to make sure you are not missing other causes. If not, then you can again try the hypoallergic formula or thickening formula. If that's work, fine. If not, then you have to try a medical management, which will come for that. And if still, then you can consider endoscopy or later on nasogastric tube. For older children with recurrent vomiting, there is not much recommendation regarding on investigation or treatment. However, you can consider endoscopy, you can consider prokinetic agent. For those older children with typical heartburn or chest pain, you can give trial of first of all the lifestyle change. If not work, then trial of BBI. If it is work, then try to wean it. If you cannot wean them, then you have to go for endoscopy. For those with esophagitis, I will skip that. For babies present with recurrent apnea, just make sure it is related, not related to serious condition like heart or CNS. And after that, you can try thickened formula, acid suppression. If the case is severe and you are still thinking most likely goes with GERD, then that's the time we'll consider fundoplication. Asthma and GERD, we don't know which one is started first, but there is no harm from trying the BBI or acid suppression for 3 months and see the response. For recurrent pneumonia, make sure you are not confusing with the aspiration due to swallowing incoordination. So they need modified barium swallow before considering this is just related to the GERD. As GERD and other stridor or hoarseness or can happen, but not all the time. So make sure it is not GERD. You can give a trial and see the response, that's fine. The treatment option for infants, start always with lifestyle change. Normalize feeding, consider thickened formula, consider trying hypoallergic formula, sleep positioning, not to put him supine position immediately after feed. For the older children, they have to avoid the large meals, working on the obesity, then avoiding caffeine, chocolate, and spicy food. For pharmacotherapy, the good things is proton pump inhibitors. Others may will help. However, proton pump inhibitors, which is the first recommended, we don't recommend antihistamine these days a lot once I have the BBI. And also prokinetic agent, if I will recommend the domperidone is the best, however, not always need domperidone. Candidate for the anti-reflux, those who failed medical therapy due to GERD, those who have, you cannot wean them from medication, or those who persistently have very bad chest issue, which you think due to the GERD. So GERD or reflux is a common in healthy infant and usually resolved by 18 months of age. Pediatric reflux can present with variable symptoms. Approach to diagnose and treat depend on presenting symptoms and signs and depend on the need for treatment. Currently available tests often don't conclusively demonstrate the relationship between the care and the specific symptoms. Good history, clinical judgment are important for optimal evaluation and management. Thank you.
Thank you, Dr. Khalid, and I think we can proceed to the second lecture directly.
Sure.
Thank you.
So, pediatric acute liver failure. I thought this is important. We just lost a girl a few months ago, and because of this condition, it happens. So it is a rare clinical condition. We know we don't see it daily, but once you have that one, then this is really very, very tough situation. Everybody should be aware about what he's doing. Frequency is in general population 17 cases per 100,000 per year. In children, the frequency it's not known. 50% of pediatric acute liver failure happened for those younger than 4 years, and we know that's because of metabolic, because of the immunity, because that's why. It accounts for 10 to 15% of those underwent pediatric liver transplant. It is a complex, multi-system, rapidly progressive clinical syndrome, significant morbidity and mortality it's carrying. So what is the definition? It is acute onset of liver disease without evidence of chronic liver disease. So if there is a chronic liver disease, then we cannot call it acute. We call it incompensated or acute on top of chronic. Sometimes we see it. They usually find biochemical evidence of severe liver injury with coagulopathy. Coagulopathy not corrected by vitamin K. If it is the INR more than 1.5 or BT more than 15 without evidence of hepatic encephalopathy, with evidence of hepatic encephalopathy, that is, we call it acute liver failure. If no encephalopathy, then you need BT more than 20 or INR more than 2 to fit the diagnosis definition. How they present? Initially, just general prodromal phase, fatigue, malaise, abdominal pain. If it is related to infection, you may have fever, nausea. So non-specific, not sensitive symptoms or signs till suddenly start to show maybe jaundice, that's alarming, or because the patient is not improving, then the doctor, they will just ordering liver function, they found the finding there, or because start to have change in behavioral or attention, which is due to encephalopathy. So what do you need to make sure? Quick things, you have to be very quick and about some clues in the etiology, recent trouble, contact with sick patient. It may give you a hint about infection. Make sure there is no medication, no herbal things given. A lot of herbal given to our babies, unfortunately. There is no mushroom, no helba sometimes in our countries. Make sure there is no family history of autoimmune disease. There is make sure about the developmental history. This baby is not developmentally delayed, doesn't have family history of liver disease. About the family history, there is no abortion, no early infant death. All these things, to give you a hint, maybe there is some metabolic issue run in the families. Examination, at the beginning, you will not find anything, a normal babies who have some symptoms, but make sure about the neurological exam, because the initial hepatic encephalopathy symptoms or signs maybe will be easily missed. Look for any sign of suggestive of underlying chronic liver disease, which missed, like growth failure, dysmorphic features, hepatosplenomegaly, ascites. Ascites is not usual with acute liver failure, clubbing or rosary, rickety rosary, or xanthoma, spidangioma, and peripheral edema. All these signs indicate this patient having a chronic liver disease, not just acute. The clinical course is rapid, dynamic, unpredictable. It's the baby or the child will progress very quick within hours and end the story. So the interval between presentation and clinic outcome, it can be very short. That is why there is urgency in establishing specific diagnosis. If you call me for such patient, you will find me ordering a lot, because I don't know if I can catch this child or know later on to do whatever remaining investigation. So yes, we start with a lot of investigation, unfortunately. Worsening clinical course did not preclude favorable outcomes. Some of them, they go very deep in very bad shape, but still they recover. Liver transplant provide a potential life-saving. Who will survive with liver transplant and who will die despite of that, we don't know. Unfortunately, we don't know. And sometimes we send babies or children for liver transplant, and in fact, if we leave them, they will survive, but we cannot carry that risk. So if you have a liver failure, what you need to do, you have to start with the liver-specific test to assess the degree of inflammation, injury, and function. So you need the enzymes, ALT, AST, GGT, alkaline phosphatase. You need to look for the function. The function, it will come from knowing the coagulation, bilirubin, protein or albumin specific, ammonia, and glucose. These indicate the function, while the other just indicate if there is any liver attacking. So what about other general tests? You need to assess other, like hematology, CBC you need the kidney function, pancreatic enzymes, you need to look for the blood gas. So this is other important things. As I said, it's multi-systemic disease. Then what is the frequency of that? Very important to keep always the neurological assessment all the time while you have a liver patient or patient with acute liver failure. So at least every 2 hours, they need neurological assessment. Also, they need the dextrose take kidney function and electrolyte. At least it depends. If they present early or in the first 2 days, you may do it even Q4 hours, but later on you can space it. What about the etiology? Unfortunately, this is one of the biggest study done where North America, where they have a lot of resources and the best lab, and still 42% indeterminate, which is very high. So with our resources, with delayed, we are expecting even more. However, one of the things, important things in the etiology here is the acetaminophen toxicity. So don't miss that. This is, you see in here at 13%, and in our country still it's very high. So that is very important because you can help them earlier. One of the things more common in our region than the North America, it's infection, definitely. So we have more infection, we have more metabolic disease. I'm not going through the etiology because that will take time. Sorry. However, for those below 3 years, you need to send for common virus, herpes, adeno, and even herpes human virus type 6, and make sure about the maternal hepatitis B status. If it is positive, then you have to check the babies. You need to send for serum amino acid, ferritin, you shouldn't miss GALD, lactate, pyruphate, and for the plasma acylcarnitine and urine succinyl acetone and newborn. So this is metabolic disease. This covering most of the metabolic disease will lead to liver failure, like galactosemia, tyrosinemia, and the mitochondrial disease. Depending on the age, you may need to send for also that, for the triglyceride. This is because of the HLH, which is one of the common causes in small babies and infants. You need to send for urine and blood cultures, and you need abdominal ultrasound, definitely. Don't forget the drug and herbal history. For those above 3 years, then again, infection, herpes, adeno, and human herpes, parvovirus, if he is one of those hemoglobinopathies, EBV, CMV, and the hepatitis panel. Check for acetaminophen level, check for the antibodies and IgG to look for autoimmune disease, ceruloplasmin, and 24 hours to make sure it's not Wilson disease. Check for ferritin triglyceride to make sure it's not the hypermicrophage syndromes, and a quick screen for the metabolic, because even the mitochondrial disease, they can present later on, and the culture, urine and blood, and ultrasound. So this the investigation you need. Liver biopsy is depend. However, if it is through the transjugular, that's safe, but nobody will do it with hemoglobin, with the coagulopathy. Management, the main things, the fluid. If they are not stable, then you need to give them whatever normal saline to stabilize. But later on, they need D10 because you need to break the catabolic status. They need half normal saline. They don't need a lot of sodium. That will lead to more extravasation of the fluid, and to keep it just 90% of maintenance. Avoid overhydration or underhydration. Both are not good for those children. So what will be your marker is the urine output. You need to check it all the time and react depend on that. You need to keep serum glucose in a good level all the time, as I said, to avoid the catabolic status. You need to maintain the sodium requirement in this normal requirement, 2 to 3. Treat the hyponatremia. You need to avoid sustained hypernatremia. It's not recommended. However, sometimes you need it. Very important things in acute liver failure is the phosphate level. Because of the regeneration, when the liver start to recover, the regeneration need a lot of phosphate. Then, so you are expecting significant drop. So keep an eye on phosphates. Try to hepatic encephalopathy. That is, we don't know exactly what's the cause. 50% they come with hepatic encephalopathy from the admission, and 65% they found it later on they can develop. The main advice, neuroobservation. If there is any altered in mental status, this could be other causes, not always hepatic encephalopathy. So make sure to rule out any infection, to make sure about electrolyte abnormality before considering that symptoms of hepatic encephalopathy. You can just review it. This is the well-known. However, in small babies, very difficult to know. So I always recommend about the mental status. If they are irritable, more crying, they are not very alert, then that is the first suspicious. If there is hepatic encephalopathy, ammonia have an essential role, but not only the cause. Those below 75, the ammonia, usually they don't develop intracranial pressure. If it is more than 200, then this is strongly associated with hepatic encephalopathy and may lead to cerebral herniation. So, however, don't rely on ammonia level. Sometimes it will be tricky and will not be give you a good correlation with hepatic encephalopathy. You need to give lactulose. It is better than rifaximin, especially in pediatric. We don't have enough studies to support rifaximin, but we use it, and the adults use it more frequent than us. Protein restriction they need minimizing the stimulation, avoid sedation if possible. If they develop cerebral edema, that's the life-threatening, and try always to avoid that. Look for any sign like pulmonary response, paroxysmal hypertension, hyperreflexia, or positive Babinski sign. That is give you a hint the patient already having cerebral edema. Then you need the EEG. Then you have to go treating those patients as increased intracranial pressure. But please, as I said, don't keep the sodium all or long time on higher side. That's not good. I'll not go over that. That's for
We have 5 minutes, Dr. Khalid.
Sure. That's any patient with increased intracranial pressure. For coagulopathy, the procoagulant proteins and the anticoagulant proteins both are dropped. So you are not expecting really a lot of risk of bleeding. Don't be very scared about the baby may bleed. In spite, some of them, they develop hypercoagulable states and they develop portal vein thrombosis while they are in acute liver failure. However, they still can bleed. And if they bleed, make sure there is no infection. Always there is participating factors. So thrombocytopenia also can happen. So usually start with vitamin K just to avoid any possibility of this coagulopathy be due to vitamin K deficiency. If not, usually the response should be very quick. If not responding, this is acute liver failure. For the kidney injury, don't worry. Most of the times it's acute kidney injury due to the nephrotoxic medication or due to systemic hypertension. So make sure to avoid those. And course sometimes will be more prolonged, but they will recover. For hepatorenal syndrome, they can develop, but usually they recover with recovering of acute or the liver failure. Metabolic.
Voice is interrupted, Dr. Khalid, مش سامعينك.
Then once you have any settled signs, then you have to.
كده تمام. تمام كده.
Okay. Then you have to go for coverage with a broad spectrum. And if prolonged patients have been there for a long time, consider even fungal coverage. They can have another complication, as I said, multisystemic. For one of the things is the gastrointestinal bleed, so that we prefer to keep them on BBI during the admission. Avoid catabolic status. And if you need a TBN, then you need to protect restrict the protein. Try to avoid lipid if the mitochondrial or the fatty acid oxidation defect suspected, and reduce or eliminate sometimes the minerals. There is different things to support the liver, but all of them is just a bridge to the liver transplant. So the end point here, if the patient always from the beginning try to refer for liver transplants, because we don't know which one will need transplant, we don't know which one will not need, and we cannot keep guessing because the patient at the end will deteriorate. So spontaneous survival is 28%. Even with those with coma, 4%, they will recover, but we don't know who. Main factors is the age, diagnosis, like acetaminophen, just start an acetylcysteine from the beginning. 94% they will recover without needing of liver transplant. So that's a good percentage. But others, it's almost 40s, in the 40s. Metabolic, drug, or indeterminate, 40% will recover spontaneously. So sometimes we run and we transplant them because we don't know which one will recover. The major cause of death, multi-organ system failure, cerebral edema, herniation, sepsis. Early and late graft loss and death is higher with those with acute liver failure. So even with liver transplant, it's not the best is to do it with those who have acute liver failure. Thank you.
Thanks a lot, Dr. Khalid, for your nice presentation. I have just one question. What is the role of ursodiol in hepatic failure and when to use it? This is from Dr. Sheikha Bawazin.
Yeah, so there is no rule for the ursodeoxycholic acid for liver failure. We use it for other causes and mainly cholestatic liver disease. And just to induce or accelerate the excretion of biles, there is some study saying having some hepatic protection but that's where not to reach to the definite. But the main thing is to enhance the excretion of the bile, but not in the acute liver failure.
Thank you so much. We are honored to have you with us, and jazakallah khairan.
Thanks a lot, Dr. Nabil. Allah yatikum al-afiyah. This is very, very huge effort, honestly. I'm appreciating what you are doing. It is something great, and I hope I add something.
Thank you so much. Yes, we learned a lot. So you can stop sharing.
Sure.
Thank you. So
I'm lost here. I don't know where.
You just stop sharing and remove from the button blue. Stop sharing. نفس المكان اللي عملت منه شير سكرين، او ممكن تلاقيه في التوب فوق ستوب شيرنج. او ممكن تعمل ليف تخرج خالص وتدخل تاني، نكون احنا عملنا شير للدكتور ايمان. لا لسه ما زالت لسه الشاشه بتاعتك موجوده يا دكتور خالد. احنا anyhow our next speaker will be دكتوره ايمان المشراوي. دكتوره ايمان is a consultant auto laryngeology, head and neck surgeon, surgery consultant in Prince Sultan Military Medical City. She's also the head of the ENT department in Saudi German Hospital, Riyadh. Welcome you, Dr. Iman. Dr. Iman will give us two lectures. The first one will be about Dr. Iman is the one we delayed yesterday because she has some issues with the connection. Now she will give us about the guideline in newborn hearing screening and congenital head and neck masses. Welcome, Dr. Iman, and it's an honor for us to have you with us. You can start share your screen.
مرحبا. Thank you very much, and sorry for the misunderstanding which was happening yesterday. This is my third year, maybe I'm contributing in this conference, and today my talk will start. I have two talks. I will start with the guideline about neonatal hearing screening. So
just share your presentation.
Yes. Okay. Do you see my screen?
Yes.
Okay, great.
Just to make full screen, yes? Okay.
neonatal hearing screening maybe for many people it's something routine or something it's well known. Unfortunately, what's happening on the ground level, maybe in the hospital, private hospital setting with a number of delivery and number of patients is small regard to the huge amount of delivery where patients deliver in a governmental hospital. Why neonatal hearing screening is important? Because a profound hearing loss, if you detect one child as early as possible, you will transfer his life to a normal child by doing cochlear implant as early as possible. In Sweden, they are doing a cochlear implant as early as 6 months. We are implanting at the age of 9 months. So early detection is very important for us. And when you detect early, you implant early, the chances for this child, if he's a normal kid, to have a normal speech and language development is extremely more than 95%. And we have a proof for that. So that's why neonatal hearing screening is a national, I can recommend, it's something that we need to be in every hospital or pediatrician before they discharge their patient from their well baby clinic, or they follow up in the first visit in the well baby clinic. We need them to ask about the hearing screening and to take care about this very important entity in the child life. So what is the definition of just I will go by simple definition. The extent of hearing loss is defined by measurable decibel, and normal hearing everybody knows from 10 to 15. I will just go quickly for some sort of refreshment for everyone, so everyone will get engaged with the idea about the hearing and what type of hearing loss that we might have and how we can detect early the hearing loss in children. The severity of hearing loss, this is according to the WHO and most of the recommendation, that slight is 16 to 25, mild 26 to 40, moderate from 41 to 55, severe we can say above from 71 to 90, and profound is more than 91. So, and this is the list of the causes of sensory hearing loss, which can be conductive hearing loss, caused by any conductive element that affecting the external auditory canal or the middle ear. And we know that in children, otitis media diffusion is a very important topic, that the majority of children, they might have a period of their life where they might have 10 to 15 decibel loss of their hearing because of the otitis media with diffusion. We can have sensory neural hearing loss. This is our fear. This is our, we are searching for this category of patients where they have damage or disease in the inner ear itself and in the cochlea. And it's we have to know there is a difference between a sensory neural hearing loss and a very big entity. We call it auditory neuropathy spectrum disorder. And most of our pediatrician, maybe they don't have the chance to differentiate between the two topics. So sensory neural hearing loss, it's per se, it's a disease of the cochlea where the hair cell is not functioning, where the rest of the auditory pathway is completely functioning normal. Auditory neuropathy spectrum disorder, or it's a cochlea that cannot detect the sound. It can detect the sound, but the signals are not transmitted properly to the from the inner ear to the brain. So auditory neuropathy spectrum disorder is characterized by, these are the children where they have, when you screen them with a normal otoacoustic emission, they will have normal otoacoustic emission because their outer hair cell is functioning normally, while the synapse to the brain to the auditory nerve is not functioning properly. So these patients and the high risk of these patients is mainly we found this category in neonatal care, intensive care unit patient. They are more prone to have such a problem, which we call it auditory neuropathy spectrum disorder. And it's a spectrum of disease. I will not go into details about it, why we call it the spectrum and how it was a misnomer, but it's a very important entity. If you need to go ahead and read about it, I would recommend any NICU physician that he needs to know about auditory neuropathy spectrum disorder. We have retrocochlear. Alhamdulillah, it's very rare, where they have the problem mainly in the brain itself. It's not in the auditory pathway. And these are, we call it central deafness. And these very extremely rare, and to detect them is extremely difficult. And thank God they are a very minute entity of our hearing loss children. And mixed, where you have combination of conductive and mixed hearing loss. So the epidemiology, just to have an idea, significant bilateral hearing loss is the most common congenital disorder at birth, and it's occur around 2 to 3%. 2 to 3 per 1,000 newborn, and this is according to the data from the Center of Disease Control. They reported a rate of a permanent hearing loss. It's 1.7 per 1,000 infants screened for hearing loss, with overall screening rate is if we reach 98%. Excluding طبعا families that they refuse the screening or the prevalence of moderate and severe and profound bilateral permanent hearing loss is around 1 in 900 to 2,500 newborn, and the prevalence of unilateral hearing impairment is around above 30 decibel, is around 6 per 1,000 newborn. These are lists of syndromes that we all know, that I'm not gonna go, but we can mention the Usher syndrome, Waardenburg syndrome, Jarvell syndromes, all of these syndromes that we are well known. Some of them, they can cause sensory neural, and some of them conductive, and some of them they can cause mixed hearing loss. So NICU patient cared for intensive care, these patients, we recommend that level 2, level 3, and level 4 are on a greater risk of developing hearing loss. So in particular, sensory neural hearing loss, and as we mentioned earlier, auditory neuropathy spectrum disorder. And the incidence is around 16.7 and 5.6 per 1,000 for sensory neural and auditory neuropathy in NICU, compared with estimated incidence of normal population of 0.06 per 1,000 infants. So this is a very precious category of patients, our babies in NICU children. Why we should screen the patient, I mentioned it very clearly at the beginning, because it's very important. Early detection, it's very important for future management of these patients. The American Academy of Pediatric Task Force on a Newborn and Infant Hearing define an effective neonatal hearing screening test as one that detect hearing loss more than 35 decibel in the better hearing and reliable in infant less than 3 months of age. These are the kind of tests that we will recommend for testing our children. We have two types of tests. We can mention it: automated ABR. It's a screening ABR. It's not diagnostic ABR. And we have the autoacoustic emission. And I will just go a little bit to explain. I know it's not, my talk is for pediatric physician, but I would love to explain more about auditory, the autoacoustic emission and automated ABR. So the pediatrician will have the sense to have the difference between the automated ABR and the autoacoustic emission. Both automated ABR and autoacoustic emission are inexpensive, portable, reproducible, and automated technique to detect, screen the hearing. They evaluate the peripheral auditory system and the cochlea, but cannot assess activity higher in the brainstem. And these tests alone are not sufficient to diagnose hearing loss. Thus, any child who fail one of these tests require further audiological assessment. In addition, both method will miss mild hearing loss. يعني هم عادة they detect minimum above 35 decibel. Automated ABR, it's a summation of action potential of 8 nerve and for 1 frequency. It's diagnostic, it's screening ABR, not diagnostic. And approximately 4% of the infants screened by automated ABR are referred for further audiological evaluation, which use a diagnostic ABR, including an evaluation by audiologists skillful enough to diagnose children with hearing loss. It is important to note that the difference between automated ABR will ABR the normal ABR, that's, as I told you, that one is diagnostic. The other one, it will give you a very specific waveform to diagnose really the level of hearing with the diagnostic ABR. While autoacoustic emission, it's measure the presence or absence of sound wave. And it's mainly these sound waves generated by the outer hair cells. So in auditory neuropathy spectrum disorder, as we mentioned earlier, the outer hair cell is functioning normally. So if you depend only on autoacoustic emission and you have a high-risk baby in NICU where they have this spectrum auditory neuropathy, you will have a normal autoacoustic emission. But the actual things that you will miss these patients. So the autoacoustic emission, it's the beauty about the autoacoustic emission, it's require less time, while automated ABR may also present time constraint because the child need to be asleep. And it's in contrast, the autoacoustic emission can be performed when infant is awake, sucking, or on pacifier. And response time is the autoacoustic emission, the beauty about it is very quick. Sometimes the interference, the autoacoustic emission, to have a sensitivity to the background noise. So sometimes it's difficult to obtain it if there is myogenic noise or poor acoustic. Sometimes also we might have false positive, which means that we don't have response of autoacoustic emission, and we label the child that is having, there is no response of autoacoustic emission, as we mentioned in patients where they have middle ear problem, where most of our kids after babies after delivery, they will have this vernix, including the external auditory canal, or there is a fluid in the amniotic fluid in the middle ear, making the autoacoustic emission having positive result, which means we cannot detect any autoacoustic emission, so the family will get panic, this child that might have a hearing loss. So that's why sometimes we need to have both tests to be done on the same time, the autoacoustic emission and the automated ABR. So in several reports, 19 to 25% of a newborn with abnormal autoacoustic emission screening during the first 3 days after birth, they have subsequent normal hearing. So because of that, you don't need sometimes people, when they relay the information to the family, you need to be very cautious how you deliver the message. And in one study, they said the cleaning the vernix increased the pass rate from 59 to 69% in these patients. It is important to recognize that, that the pass threshold is higher for autoacoustic emission than for ABR, resulting in high failure rate. So both, this is very, very important that you need to know that you cannot depend on one test for screening these children. And as we mentioned earlier, both of them will miss mild and minimal hearing loss. We require normal tympanic membrane mobility in autoacoustic emission. Also in autoacoustic emission, as we mentioned earlier, it will miss patients with auditory neuropathy where they have normal. When you do autoacoustic emission, it will come normal, positive. It will give you yes response. So it's you think that you will deliver the message to the family that your child is having normal hearing, although this child from the high risk category where you need to test them by both doing automated ABR and autoacoustic emission. The cost, although the actual screening cost is lower with autoacoustic emission with comparing to automated ABR because the consumable with the automated ABR is higher cost, but in the other way around, if you look at it, the referral rate to do more tests with ABR, with autoacoustic emission will make the price higher with autoacoustic emission for the future testing. This is all of, we know that these are the risk factor that for auditory neuropathy or in the hearing loss in general. We know that sometimes acquired or prenatal, postnatal or genetic factor. People might mentioning that let's go for selective screening. There is a strong evidence that if we miss or delay detecting hearing loss is very significant and it's no longer recommended. Universal screening for all newborn infants is supported by a global health organization. It's out of date now that they said that we screen only the high risk children. A targeted screening program using the risk, as discussed before, identify only 50 to 75% of infants with the moderate to profound hearing loss, and the time of the diagnosis, usually it's delayed. And as you mentioned, if you want to do a cochlear implant or if you want to put them on hearing aid, you want them to put these supportive measure, we want to start it as early as 6 months of age. In addition, selective screening alone delay the detection of hearing loss in a big number of children with congenital deafness who don't have any identifiable risk factor. Therefore, targeted screening, it's out of date, it's not recommended. The goal of newborn hearing screening is early recognition and treatment of hearing loss. With the widespread adoption of the universal neonatal hearing screening, we can identify, we lower the range of identifying children with hearing loss from 24, 30 months to 2 to 3 months of age. So this is something very important, and I think it's require attention and require that all of our pediatricians to adopt neonatal newborn hearing screening. Reported data from Center of Disease Control from 74, just an assumption that from 74 states and 7 territories show that 98% of birth, 3.5 million infants, excluding refusal, were screened, of which 1.7 infants, which is the number of 61,000, didn't pass the final newborn hearing. in the group that did not pass the newborn hearing, 9.7 of these infants were diagnosed with a permanent hearing loss, which is a prevalence of 1.7 over 1,000. 2/3 of infants diagnosed with hearing loss were actively enrolled in early intervention. In the United States, and I have to mention all the most of the guidelines coming from United States, unfortunately they are the most very clear guideline that we can adopt. They implemented early detection for these children, and this guideline for early detection should be screened before they reach the age of 1 month, either by doing autoacoustic emission or automated ABR. And audiological assessment of all of the children who failed the screening test should be done by the age of 3 months. What's happened in Qatar, for example, what they do, because sometimes it's not easy, especially where, as I mentioned, in a governmental hospital where a lot of children where they discharge from the will-be nursery as less than 24 hours, they ask, they put the neonatal hearing screening with their card of vaccination card when they come for the vaccination at the age of 2 months. So from there, they pick all the family for neonatal hearing screening. Some of the people, they don't recommend this technique because they said we might lose patient, but unfortunately, this is from my recommendation, if we fail to the obligation of neonatal hearing screening as early as possible, we should adapt this technique as at least we can grab these patients as early enough at the age of 2 months. So we need to have, if we have an intervention, it should be started at the age of 6 months to have a final diagnosis. We have 2 types of stages protocol, single stage or 2-stage protocol, and I'm just gonna do just a quick discussion about, and then you can have the choice whether you will adapt the single stage or 2-stage protocol. A single stage protocol is a screening test, either automated ABR or autoacoustic emission. It can detect 80 to 95% of the ear with hearing impairment. Then we refer for audiology evaluation, and generally required for 4% of infants screened by ABR, and 5 to 25% of the infant for automated autoacoustic emission. The prevalence of moderate to severe hearing loss in this type to be 1 case in 900 to 2,500 newborn infants. And I need you just bear with me with these numbers so you can differentiate between single stage and 2-stage hearing protocol. Thus, for 1 significant hearing loss, the number of infants with normal hearing referred to audiology assessment after single screening would range from 40 to 500. As a result, the majority of United States hospitals now have adopted a 2-stage technique because there is a high number of referral for testing with 1-stage technique. They adopt the 2-stage technique. The 2-stage screening is a second screen is given to the patient who failed the initial screen, and only patient who failed the second screen referred for audiological assessment. So the 2-stage protocol is preferred as it reduces the rate of false positive and reduce the referral rate for audiological assessment. And this is the 2-stage. Maybe the time is not with me to explain. This is the 2-stage protocol for the neonatal care in Will Baby Nursery, neonatal level 1. And this is, as you see here, if they pass, discharge home. If they fail, you need to test them again. And this is for if we are dealing with the neonatal level 2 and 3, the idea is different now. You have to be very cautious, and you have to do a diagnostic test before hospital discharge home. The 2-stage protocol is preferred, and it reduced the rate of false positive, as we mentioned. Data from the study utilizing the 2-stage protocol that approximately 900 to 1,400 infants who need to be screened to identify 1 case of bilateral hearing loss compared to the other 1-stage protocol. It's estimated that 1 of every 45 infants from the Will Baby Nursery referred for audiological evaluation by 2-stage protocol would have moderate to profound hearing loss. So because of this finding, however, the two-stage protocol also, it's not, it can miss also sometimes some of the children, especially patients who develop later on, like patient with cytomegalovirus infection and patient who develop later on hearing loss. So that's why, in addition, the screening device currently available have a threshold of approximately 35 decibel and will miss mild hearing loss and delay diagnosis of hearing loss. Because of this, continued surveillance of hearing skills and language development, as described by the American Academy, periodically check is recommended by the American Academy of Pediatrics. So which means that we cannot depend on the screening by itself. We need to follow these patients at least at the age of 9 months to have another audiological assessment. It's in summary, I'm going just.
We have 2 minutes for this presentation, then we'll go to this.
Just in summary, in Will Baby Clinic, in nursery setting, neonatal level 1, we suggest performing two-stage neonatal hearing screening to reduce the number of infants who transfer to audiological tests. Infants are screened initially with autoacoustic emission, and those who fail autoacoustic emission, we need to do autoacoustic plus automated ABR. Also, each infant should have at least one assessment at the age of 9 months. This is what we mentioned, that we have to continue surveillance of children. And if a program decides to utilize one stage of neonatal hearing loss, it's recommended as a result of lower false positive and lower rate of referral for audiological assessment, to use automated ABR rather than autoacoustic emission alone. Yani if you decide your center to decide to use the one stage, we prefer that you use automated ABR rather than autoacoustic emission only. And in NICU, for infant admitted to NICU, automated ABR is the initial recommended due to the increased risk of auditory neuropathy in these patients. And then this approach concurs with the guideline of the Joint Committee of Hearing in Children. And for all infants, regardless of the result of the screening test, continued surveillance by a primary care provider for hearing problem is recommended and include assessment of development of milestones, speech, auditory skill, and parental concern. I think I will stop here because it's all of it, it's repetition and re-emphasizes of what I mentioned before about the whether you adapt single stage or two-stage protocol, whether you are dealing with neonatal level 2 or 3 or 4, or you are dealing with Will Baby Clinic. And thank you very much.
Thank you so much, Dr. Iman, for this. As you know, here in the Kingdom, the neonatal screening is a national program, and it is being done for every baby, normal or in the NICU. Besides, we are doing it exclusively for those patients who have risk, for example, for ototoxic drugs or after meningitis, but there is a running national program for screening for all babies.
Unfortunately, Dr. Nabil, yes, it is a national program, but always if you come to our meetings, and you will see that this national program, it have a lot of obstacles to really to make it possible, as because of this high number of delivery, because these babies, they don't stay more than 24 hours in the hospital. So we have a lot, you cannot compare the experience in private sector with the experience in the governmental sector. So still, I think we need to re-emphasize our technique about neonatal hearing screening in hospital where the number of births per day is very high. Thank you very much.
Thank you so much. We can go direct to the second presentation.
Okay. This topic is more of, or less, is more of, I would love usually I do this topic as a kind of interactive discussion with with a lot of physicians, so we can reach to how we can approach these children with congenital neck masses. Approach for diagnosis in this patient usually depend on the patient age, history, and the growth patterns, symptoms, physical examination, mass localization, and mass characteristic. Radiological investigation and other diagnostic tests. So by putting all of these things in your mind, you will reach to your final diagnosis and referral to the subspecialty in concern is very important, where pediatric otorhinolaryngology, they deal with most of these congenital head and neck masses. As we mentioned, you can, from the location of the mass, you can divide whether it's a midline or lateral neck mass. Midline, the most common one is thyroglossal duct cyst, as we mentioned, submental lymphadenopathy, dermoid, cleft, or teratoma. While the lateral, we are talking now about the branchial anomalies, lymphatic anomaly, thyroid nodule, thymic, laryngocele, or sialadenitis. This is an example of a patient that's come to you at the age of 2 years, 3 years, complaining of small midline swelling that appears suddenly after an upper respiratory tract infection. It's sometimes it's when the first presentation, usually actually these patients, they present usually with the first presentation with an infection, an abscess formation. And most of these, the most common is the kind of midline neck masses is the thyroglossal duct cyst, and it's around occurring around 2 to 4% of all neck masses, and it's the most common type of congenital neck masses. The infrahyoid type is the most, there is a different level, and usually it is related to the delivery of the thyroid itself. So it might be infrahyoid or suprahyoid, and the infrahyoid type is around 65% of all thyroglossal duct cysts. And the other one is the suprahyoid mass. Intralaryngeal thyroglossal duct cyst, alhamdulillah, it's very rare. Patients usually, as I mentioned, they present with cystic midline mass, and the differential diagnosis could be thyroglossal duct cyst, could be dermoid, and could be the lymph node. Actually, the differential diagnosis, usually you go ahead and you go by doing ultrasound, and it will show you or fine needle aspiration. As we know, the fine needle aspiration, they will have these cysts, they have squamous epithelium and ciliated columnar epithelium in their wall. In this patient, I can do sometimes ultrasound by itself is enough to diagnose this patient, but usually, and very important to do ultrasound to see whether you have a normal thyroid or not, because sometimes these cysts, they present in the only functioning thyroid tissue in this baby. So ultrasound is very important. And we go, most of the patient, we can do CT scan, so we know the allocation of the cyst, and it's very clear. You will see here a cystic lesion with circumferential enhancement, and the relation with the thyroid cartilage and the thyroid itself, it will give you a very high differential diagnosis of, you will put it on the top, thyroglossal duct cyst. And this is in T1 and T2 MRI. Usually we don't do MRI for this patient. Ultrasound, CT scan is more than enough. If we diagnose, what's the next? If we diagnose, the risk of infection is very high in these children. So that's why we told the family that 50% they will have a chance of infection, and in infected cases, thyroglossal duct cyst, doing surgery for these patients is very difficult if it's infected. So that's why as soon as I diagnose thyroglossal duct cyst, I recommend the family, and the family, they can decide that we need to surgically excise this cyst. Also, there is 1 to 2, very small percentage, but 1 to 2% chance that this might change into malignancy. And how to differentiate it between malignancy, I will not go into discussion today. It's away from our topic. The surgery, we do go and we do what we call a cyst trunk procedure, where we follow the cyst and we remove the body of the hyoid. If you don't remove the body of the hyoid, there is a very high risk that this cyst will recur again, because the tract will pass through the body of the hyoid down up to the base of the tongue. So part of the surgery include removal of the body of the hyoid is must and highly recommended to prevent recurrence in these patients. The second thing is the dermoid cyst, and it's, as we know, it's composed of 1 or 2 germ cells, and it's ectoderm and or mesoderm, and it's around 20% of all head and neck tumors or masses, and most commonly they don't present in the neck, rather than they present in the periorbital or nasal or scalp, and usually it's a painless, and also the treatment is surgical excision. The most important to me today, I will concentrate on, and maybe I will mention a couple of others, is the branchial arch anomaly. The branchial arch anomaly, as we mentioned, is the second most common after thyroglossal cyst, and it's around 30% of all head and neck lesion after thyroglossal cyst, duct cyst in children. All of us know our branchial arches, and we know the first branchial arch will give you the external canal. Second and third and fourth will coalesce together to form the cervical of Hens, and if they don't, they will give you a cleft or fistula or cyst. Cysts are considered entrapment of the branchial cleft or pouch. Sinus are remnant of the cleft. And the fistula is connection between both pouch and the cleft. Let's talk about the first branchial arch anomaly. It's rare, but I would love to start from the first, second, and third and fourth. Second is the most common, but the first is around from 5 to 25% of branchial arch anomaly, and you have two classification, the work classification type 1, this is the most recommended one, where you have either periauricular sinus or mass. It contains ectoderm only, and it has a relationship with the facial nerve. So sometimes you have the patient presented with mass in the mass or sinus or cyst here in the periauricular area, and sometimes they only present with the discharging ear otorrhea. And usually in a very young patient, you need to think about type 1 branchial arch anomaly. Type 2, the opening is more rather than at the angle of the mandible, or sometimes the cyst will present at the angle of the mandible, and the tract, it might go up to the external canal. And it has a relationship with the facial nerve. Exciting this mass cyst usually carry high risk of traumatizing the facial nerve, unfortunately. Usually children, they will present with recurrent neck abscess in this patient. Most of the branchial arch anomaly patient will present with recurrent neck abscess. And unfortunately, many times patient being drained and open many times before they refer them to the pediatric ENT, where removing of this mass after several times incision and drainage will carry a high risk for complication. So that's why we'd love to emphasize that, refer them as early as possible. 1 second. And this is if you find any cyst that allocated in this area, always think about first branchial arch anomaly. This is kind of how a defect in the first branchial arch can present, as we know, Treacher-Collins syndrome or Pierre-Robin syndrome. The most common, and this is a cyst within the parotid gland, and this is resembling, and sometimes one of the treatment of these patients is superficial parotidectomy, because you want to excise the cyst that representing a cyst coming from the first branchial arch. نيجي عاد the most important one is second branchial arch anomaly, and usually it's present as a mass allocated anterior and medial to the sternocleidomastoid. Sometimes it presents as like a fistula on the right side, 89%, or very rarely bilateral presentation in broncho-otorenal syndrome, طبعا in which audiogram and renal ultrasound is very important. The most common type طبعا في subclassification for second branchial arch anomaly. The most type is type 2, where it is adjacent to the carotid sheath. The removal of the second branchial arch anomaly, it has a strong relation to the carotid sheath, so that's why a surgeon, a pediatric ENT who knows the anatomy, who knows the embryology of this disease, I think is the best surgeon who can deal with such anomalies. This is an example of a second branchial arch anomaly deep to the sternocleidomastoid. Usually they present actually in the after age of 7 years. Most of the patients we saw here after the age of 7 years. نيجي عادة اللي هي very rare, but usually we face a problem in the referral of these patients. The third, and I mentioned third and fourth because it's very difficult to differentiate between the two. These patients usually they present with recurrent neck abscess. Recurrent neck abscess just near to the thyroid gland, and usually they think it's a thyroid abscess, while usually it's very rare to find a thyroid abscess in pediatric patient. If you think about this, always think about third and fourth branchial arch anomaly. Sometimes even they present as a suppurative thyroiditis. And it will follow the embryology of the fourth and third branchial arches. But the most important that we know that it has a strong relation to the thyroid glands, and removing, if we go for exact for surgical resection, a thyroid lobectomy should be included in the surgery of this patient. And this is a photo that shows you the different type of cysts that can present in the head and neck in relation to the branchial arch anomaly. Here, type 1, where they are present mainly, as we mentioned, in the relation to the mandible, where anything in front of the sternocleidomastoid is a second branchial arch. Anything in related to the thyroid gland is third and fourth branchial arch anomaly. And most of these patients, what part of the workup is ultrasound, and after that we do CT scan, and from the location of the mass we can judge what type of surgery, the type of branchial arch anomaly, and the surgical excision of this mass is the most recommended treatment. And actually, sometimes in acute cases where we need to do aspiration to treat the infection, then later on we'll take the patient after resolving of the infection for surgical excision. Do I have time, Dr. Nabil? Hello?
معلش.
How many minutes still I have? Because I will go for the other
10 minutes.
How many?
You have 10 minutes.
Okay, good. So the other important, الآن تكلمنا عن الثايروغلوسال duct cyst، بعدين تكلمنا عن البرانكيال arch anomaly. أهم حاجة عندنا الآن الفاسكولار malformation. الفاسكولار malformation, the most recommended classification is the for vascular malformation is the neoplastic and vasoproliferative or vascular malformation. الفازوبروليفراتيف اللي احنا بنتكلم عن الانفنتايل هيمانجيوما، نتكلم عن الكونجينيتال هيمانجيوما and the spindle cell tumor and cancer. These are very rare, but the most common from the vascular vasoproliferative is the infantile hemangioma. For the vascular malformation, they divided into slow flow vascular malformation and fast flow vascular malformation. And one of the most common slow flow اللي هي lymphatic malformation. هذول أكثر اثنين حنتكلم عنهم. حنتكلم عن infantile hemangioma and lymphatic malformation. Actually صراحة هذول أكثر شيء اللي أنا حاليا يعني with all our for the last 15 years I see most of these two categories. I see them with the vascular malformation. Infantile hemangioma is the most common tumor in infancy and presents shortly after birth, and it's proliferating during the first 9 months of life, and it will involute after 18 to 24 of life. طبعا احنا عارفين الريسك فاكتور usually البرايميز, الفيميل more, Caucasian more, infant born with a mother of history of chronic villus samplings, pre-eclampsia and placenta previa also at risk. And usually it's around 80% of them they are solitary lesion. طبعا في عندنا موضوع النيومنكليكت الاسامي او الكلاسيفيكيشن. most of the يعني recommended one الان اللي هي the combination is a focal or segmental. focal اللي هي localized or segmental diffuse hemangiomas. Diagnosis طبعا everybody know the best diagnosis for this patient is doing CT and MRI. And CT you can see here, the MRI here you can see they have high intake in T2 and iso intense in T1. And here in CT scan they are well circumscribed and a very high flow and very highly intense masses. I don't want to go into detail about CT and MRI. I just want to go about the treatment in this patient and the invention of propranolol in this patient. Usually before we started with the treatment, this patient we used to start treatment by steroid. But nowadays, number one of treatment of infantile hemangioma is propranolol. And it's the first line of treatment with a doses of 2 milligrams per kg per day for 12 months minimum. Sometimes we can go up to 24 months. 90% of the patients will show the result in 1 to 2 weeks. But the most important, you know, the side effect of propranolol, you need to have a cardiology clearance and the risk of hypoglycemia, lethargy. You need to explain all of this to the family. But some of the programs, they recommended started propranolol at in-house in the hospital, monitor the baby for a couple of days, then discharge them on the medication. And most of the, our patient nowadays, we started them on propranolol as an outpatient. Alhamdulillah, we don't see any complication happening for propranolol, and really tremendous result and tremendous outcome with the use of propranolol in these patients. طبعا البريدنيسولون كنا نستخدم زمان اللي هي البريدنيسولون we give a very high dose 2 to 5 milligram per kg per day at least for 4 to 12 weeks, and we can think about how the adverse effect of giving a prednisolone in this steroid in this patient. Vincristine, alpha 1, it's all out of date nowadays. With the invention of propranolol, it's either propranolol. If it is resistant to propranolol, usually we don't start other treatment. طبعا surgical excision إذا كان عندنا poor involution أو بعد ما it will involute to decrease the scarring effect after the redundancy of the skin. What is the complication? The complication is of the hemangioma is airway compromise. Sometimes we have associated with, especially with the segmental beer distribution hemangioma, we should do a direct laryngobronchoscopy to rule out a very important type of hemangioma where they go into the subglottic area, which we call it subglottic hemangioma. These patients, they will present with a stridor, and they might have a severe significant stridor. So direct laryngobronchoscopy is very important. Ulceration and ophthalmic complication and high output failure is very, it's one of the complication of hemangioma. As we mentioned, as I told you, any patient with a segmental distribution hemangioma, please refer these patients to pediatric ENT to do direct laryngobronchoscopy to rule out the presence of subglottic hemangioma. طبعا احنا عارفين الميريت سيندروم اللي هو كواجيلوباثي بتحصل and thrombocytopenia. هذه another complication happen from hemangioma. Faces syndrome طبعا nowadays any child with segment, especially the beer distribution hemangioma, we need to do MRI brain to rule out faces syndrome where they have posterior fossa malformation, segmental hemangioma, arterial abnormality, and coarctation of the aorta and eye abnormality. Unfortunately, patient with faces syndrome, we should be very cautious in administering, giving them a propranolol because of the arterial abnormality they have in their brain. So that we need to ناخذ clearance من الكارديولوجي before we start a propranolol in this patient. نيجي another very important entity اللي هي الفاسكولار malformation. الفاسكولار malformation نتيجة lymphatic malformation. This is the most common slow vascular malformation, and it's because of إنه lymphatic space خلاص بيصير budding and it's open. They channel تفتح على بعض. They open and they connected to each other. Incidence it's quite low. It's not that quite low, but it's quite low, around 2 per 1,000 live birth. الميل أكثر من الفيميل. And usually lymphatic malformation nowadays I've been called many times by the feto-maternal. They would diagnose them in utero. And sometimes at the age of 2 years, because lymphatic malformation usually starts small, and with time these vascular spaces they open and they become very big with time. طبعا classification, the most important classification nowadays I'd love to have is the macrocystic and microcystic. It depends whether it's one cyst or several small cysts. And always remember, the microcystic type is the more difficult and more, it's a surgical treatment, while the macrocystic is more easy surgery, but also respond to adjuvant therapy. And the location usually either suprahyoid or infrahyoid. This is another classification. Suprahyoid always associated with a very bad airway problem, so sometimes you need to do tracheostomy in this patient. And we know that they are transilluminate. Sometimes, many times, most of the time, we need to do exit procedure. In some of the cases where they grow tremendously in utero, and we have quite experience in doing
1 minute
exit procedure in this patient. طبعا بس حبيت أوريكم الفرق between المicrocystic والmacrocystic. This is a macrocystic disease. You can see they are very big spaces, very big cysts with interceptation between them, while the microcystic, you can see the multicystic, and they are very small, tiny lesions. طبعا بالنسبة زي ما الفرق between الماكروسيستيك is more of we can do adjuvant therapy where we can do inject bleomycin, doxycycline, OK432 is a kind of adjuvant sclerotherapy by the interventional radiology, and they give excellent result. While microcystis, because they are the injection of the sclerotherapeutic agent will not go to the whole cyst, so the outcome is very poor, and the best result is with the surgical excision. This is my end of my talk. I just given a small highlight about the most common vascular congenital neck masses in pediatric, and thank you very much.
Thank you, Dr. Ayman. I have just one question from Dr. Ragad. in Egypt. Is there a criteria to start propranolol even if the hemangioma is a small size?
It depends. If the hemangioma is very localized and very small size and not causing any disfiguring for the children, usually we monitor them. While the propranolol, usually we reserve it mainly for cases where they have segmental hemangioma, where they have hemangioma causing severe disfigurement, and airway hemangioma. Because before in airway hemangioma, we used to do laser, we used to do sometimes laryngofissure. Nowadays, no, we start them on propranolol. So if it is a small hemangioma in an area not very disfiguring, we just keep watching them. And actually what we do here in Riyadh, we have multidisciplinary team where we have the hematologist, pediatric ENT, and the pediatric dermatology. All of us, we sit in one clinic and we see patients, and accordingly we decide who to start propranolol on.
Thank you so much, Dr. Iman, for your valuable lectures, and thanks for being with us, and sorry to disturb your time. We hope you, inshallah, safe arrival. You can stop sharing.
Yes, thank you very much.
Thank you. Now we'll go to our last speaker, مسك الختام from Egypt, الدنيا, Dr. Ragad Ali. Dr. Ragad, she is consultant and head of the Department of Pediatric and Neonatology Department in Ahmed Maher Talimi in Egypt. Dr. Ragad will speak to us about vitamin A. And I hope that she will have time, because we took from her time about 5 minutes. So we will, inshallah, compensate. We'll compensate you, inshallah. طيب دكتورة إيمان، ما زالت الشاشة بتاعتك شيرد.
طب إيش أعمل؟ زمان عن الموضوع.
بس اعملي ستوب شيرنج، أو ممكن تخرجي مثلا وترجعي تدخلي تاني لو أنت عايزة. هو هيكون في البار يا اللي تحت يا اللي فوق ستوب شيرنج.
ايوه بس ثواني دكتور، مش عارفه اوصل لها، مش قابله تطلع.
طب اعملي ليف
لحظه. اي ويل ليف. يس ذا بيست.
ايوه ليف. لا تليف وترجعي. ليف وبنار. يلا اهلا دكتوره رغد.
اهلا بحضرتك، مساء الخير.
مساء الخير. يلا حضرتك خدي بقى زي ما انت عايزه لحد الصبح احنا معاك.
لا يا فندم، انا عارفه ان انتوا طبعا تعبتوا والوقت صعب، فانا ان شاء الله مش هتاخر. بسم الله الرحمن الرحيم. الأول طبعا I would like to thank Dr. Nabil for his kind invitation. It's my honor and pleasure حقيقي إن أنا أكون with حضراتكم in such an elegant, fruitful, حقيقي very useful conference. I enjoyed a lot. Congratulations طبعا for the amazing success yesterday, today, and wishing more and more achievement tomorrow إن شاء الله.
Thank you so much.
I will start my talk. It's about vitamin A deficiency versus toxicity. I have nothing to disclose. This topic has been chosen because vitamin A supplementation has been scheduled in many countries and even in Egypt as well. It's recently has been scheduled. We are faced with many questions from the parents. One of these important questions, if the child is on multivitamins, would he or she receive vitamin A doses of that given by the Ministry of Health? To answer this question, let's remind حضراتكم with vitamin A. I will go through what is vitamin A, its metabolism, what's the food rich in vitamin A, action of vitamin A, its role, either criteria or diagnosis, how to diagnose deficiency of vitamin A and how to prevent, manage deficiency. And a very important, the main goal of this topic is to clarify points to avoid toxicity of vitamin A. As we all know, vitamins are organic substances that cannot be sensitized by human and must be ingested in the diet to facilitate normal metabolism. They are either water-soluble or fat-soluble vitamins. Vitamin A is one of the fat-soluble vitamins. That is to say, it is hydrophobic, stored in the body. Deficiency arises lower onset and more common to cause toxicity. Ancient Egyptians used powdered liver rich in vitamin A to cure night blindness. And then, after the ancient Egyptian, Hippocrates first described nyctalopia, which is night blindness. In the Middle Age, a Dutch physician wrote a poem: "Who does not at night see right, eat the liver of a goat, he will then see better at night." And then later on in the early 20th century, they linked vitamin A or Z factor, not identified yet and not named yet vitamin A deficiency, with cessation of corneal defect, night blindness, and growth retardation. In 1907, they discovered of a fat-soluble factor essential for growth and survival. Until in the late 1920s, the fat-soluble compound in liver was isolated and termed vitamin A by this chemist. There are two main forms of vitamin A: the provitamin A, carotenoid, and the preformed vitamin A. The provitamin A, this is the one found in plants, metabolized by mammals into the vitamin A, less likely to cause toxicity, and we'll explain it very soon. Preformed vitamin A is that found in animals, the form supplied by most supplements used to give to our children, and it is more likely to cause toxicity. If we give a characteristic, a well-known example, it is the provitamin A, it's the carrot, and the chicken of a liver, that's preformed vitamin A. We take both sources of the plant and animal vitamin A from different sources. If you review the metabolism very quickly, the metabolism of provitamin A into active vitamin A is a highly regulated step. So excessive intake of vitamin A from plant sources is very unlikely to cause toxicity. On the opposite side, absorption and storage of preformed vitamin A is efficient, and toxicity can occur if excessive quantity are ingested. Why? Because most of the provitamin A to be absorbed, it needs to be cleaved to retinol before absorption. This step is subjected to feedback regulation, which depend on the status of the vitamin A in the body. If there's much vitamin A in the body, then it will not be cleaved, and then it will stop more absorption. On the opposite side, the preformed vitamin A is hydrolyzed into retinal in lumen of the intestine. This very shortly, then the absorption depends upon the type. The carotenoids will be cleaved and changed into retinal. Retinol esters involved in the hydrolysis of retinol. Both are then absorbed. The pancreatic enzyme play a role in this, and then they are absorbed, incorporated into the chylomicrons to be absorbed and to be passed in the lymphatics and the plasma, up to it reach to the hepatocyte, taken up by the liver, where it is metabolized, broken down. At the end, they will be stored in the stylet cell, known as a well-known cell, where then it will be stored there. In order for that vitamin A stored in the liver to reach its target cell, it needs to be hydrolyzed and taken by a retinol binding protein to form retinol binding protein complex and reach the target cell. This is very important. We have to understand this point because it will influence our understanding of the toxicity. As the ancient Egyptian, this is the stellate cell used to be given by the ancient Egyptian, the vitamin A containing lipid globules within the hepatic stellate cell. About 80% of the total body retinol is stored in the liver. That is distributed in other tissues, but much less in amount. If we're going to start talking about the action of vitamin E, as we all know, it prevention of xerophthalmia, which is abnormality in the corneal and conjunctival development. It is important in the phototransduction, which is conversion of light into a change in the electric potential across the cell membrane. Two types of photoreceptor, as we all know, the cone cells, and we are minded with the rod cells, detect motion and are responsible for night vision. All the cells in the conjunctiva and the retina have retinol binding protein, suggesting that it depends on the dependence of this tissue on the retinoic acid. And the normal fetal development of the eye also require adequate vitamin A intake and storage. What about the causes of vitamin A deficiency? Vitamin A deficiency is rarely seen in resource-rich countries. Always the cause of vitamin A will be bariatric surgery, gastric bypass, disorder associated with malabsorption, cystic fibrosis, pancreatic insufficiency, or celiac disease. On the other hand, malnutrition may be the main cause in resource-limited countries. Approximately 30% among children under age 5 worldwide, and nearly 50% in young children in Asia and in some parts of Africa will have vitamin A deficiency, will have night blindness, complete blindness, advanced stage of xerophthalmia. This unfortunately may lead to blindness. Thus, we are confronted with a public health problem. Approximately 500,000 preschool children become blind each year, every year. Let's raise the routine distribution of vitamin A, how it is important to children in endemic area, prevent this ophthalmic complication. Even one study that vitamin A supplementation to children in an undernourished population reduce the long-term risk of hearing loss among those with ear discharge. We consider the ear discharge, or this study considered the ear discharge as a marker of otitis. Let me highlight some points on the vitamin A deficiency. We, in the metabolism, we clarified that storage of retinol is in the lipid droplet in the liver. The high capacity of this storage will mean that well-nourished human can go months on the vitamin A and B carotene deficiency diet while maintaining the blood level in the normal range. We need then how we can diagnose deficiency of vitamin A, maybe by the clinical findings and supported by measurement of serum retinol level. It needs to be fasting specimen and it's not cheap to have this test. Serum carotene level are typically low in patients with vitamin A deficiency, and low serum carotene can be used as a part of malabsorption and nutritional status. But please take in consideration there's some situation where there underestimation of vitamin A stores, as in severe systemic inflammatory disease. There is decrease in the carrier protein. We mentioned the retinol binding protein, and due to redistribution resulting in capillary leak. Also, in severe malnutrition, serum retinol level are low because dietary protein energy and zinc are required for synthesis of protein, retinol binding protein. Controversially, on the opposite side, in a patient with vitamin A deficiency, a dose of vitamin A may cause a transient rise in serum retinol concentration, leading to overestimation of patient vitamin A stores. So we have to be minded by these issues when we investigate for vitamin A deficiency. As for the clinical picture, we all know that the pathological dryness of the conjunctiva and cornea caused by inadequate function of the lacrimal gland, resulting in mitotic spot, which is an area of abnormal squamous cell proliferation and keratinization of the conjunctiva, as you see. Progressing to corneal xerosis and keratomalacia. Night blindness may be a result, and retinopathy, the advanced stage of this ophthalmic manifestation, xerophthalmia, may be even irreversible and cause blindness. As we mentioned, there is xerophthalmia, and in addition to xerophthalmia, there are other parts of the body may be affected: the poor bone growth, impaired humoral and cell-mediated immune system, and non-specific dermatological problems in the form of hyperkeratosis, destruction of hair follicle, and the replacement by mucus-secreting glands. The WHO recommended replacement supplementation for population endemic for vitamin A deficiency infant from 6 to 12 months needs to take 100,000 international unit, 1 dose, and from 12 to nearly 5 years months of age, 1 to 5 year of age will take 200,000 international unit. This to be repeated every 6 months. As for pregnant mother living in area where there is deficiency, or suspecting there is risk for deficiency should receive vitamin A to prevent night blindness. But this supplementation, it need to be frequent small doses, 10,000 international unit daily or 25,000 international unit weekly for a minimum of 12 months. High doses supplementation should not be given because of potential teratogenic effect. Supplementation is no longer recommended for neonates or infants from 1 to 5 months or to mother during the postpartum period living in endemic area. There is another supplementation named targeted supplementation for children at high risk of vitamin A deficiency and suffering from measles, diarrhea, respiratory disease, severe malnutrition, who live among population at risk of a vitamin A deficiency or having an underlying cause of vitamin A deficiency, and have not, for those in the risk of vitamin A deficiency and have not received supplement within the past 1 to 4 months. Those infants who WHA recommend, infants from less than 6 months will receive 100 international unit. From 6 to 12 months will receive 100,000 international unit. Children more than 1 year will receive 200,000 international unit. What about very low birth weight infants? Limited evidence suggests that vitamin A supplementation helps to prevent bronchopulmonary dysplasia, or no much evidence suggests for the role in preventing ROP and necrotizing enterocolitis. This is one of the systemic review and meta-analysis titled Vitamin A Supplementation Prevents the Bronchopulmonary Dysplasia in Preterm Infant. Vitamin mentioned that the vitamin A supplementation is beneficial to the prophylaxis of bronchopulmonary dysplasia in preterm infant. Further studies on the administration approach and doses of vitamin A in preterm are warranted. This study has been discussing what are the doses, what are the ideal doses, and the frequency of giving vitamin A, whether to be given in the intramuscular, or one of them has been gave the international unit of vitamin A per oral. And what about the frequency of giving such vitamin, whether there is toxicity or not? In addition to the therapeutic use, the dermatologists, as we all know, care for a great extent for vitamin A, whether they use it topically or systematically. It manages psoriasis, disorder of keratinization, skin cancer, acne-related disorder because hyperpigmentation and wrinkling associated with sun exposure, because retinoic acid reduced the proliferation of sebaceous glands. Also, vitamin A has been used for atherosclerosis and acute promyelocytic leukemia. Here we have to stop for a while and have the judge between vitamin A deficiency or toxicity. We have to remind ourselves what are the drugs we are giving, or what are the supplements, the vitamins we are giving, and the dose of vitamin A in each of this supplement. Because there is excess, there is toxicity due to the chronic ingestion of large amount of synthetic preformed vitamin A, 10 times higher than the recommended daily allowance. And it's we all familiar now with the candy-like supplement used to be given to the children. This candy-like supplement would be miscible emulsified, and the solid form of this will have higher rate of toxicity. By contrast, as we mentioned, the release of the provitamin A from plant source is highly regulated. Individual who ingest large amount will develop large amount of provitamin A for sure, will develop what is called carotenemia without developing vitamin A toxicity. And we all know that carotenemia is common among infant and toddler eating large amount of puree vegetables characteristic of the carrot. It must not be confused with jaundice. The skin discoloration will result spontaneously if the intake of this food is reduced. And as we all know, that carotene is excreted in the sebaceous gland, thus the yellowing of the body, but not the sclera. The sclera is spared. There's other causes for catecholamia. There's nephrosis and hypothyroidism. And this is due to another issue, this decreased conversion of beta carotene into retinol. We are confronted with three types or three syndromes of vitamin A toxicity: the acute, the chronic, and we have mentioned already the teratogenic effect of vitamin A. What are the actual doses of vitamin A toxicity? Actually, it's not established, because we all now know that the large storage capacity of the liver for vitamin A. It occurs in adults when a single dose of more than 660,000 international units is ingested. There is symptoms for the toxicity as nausea, vomiting, vertigo, blurring of vision. In very high dose, then develop drowsiness, malaise, recurrent vomiting can follow the initial symptoms. In infants under 6 months of age, as little as 20,000 international unit daily, given briefly, may produce toxic effect. And this has to be put in our mind. Chronic toxicity occur with long-term ingestion of vitamin A. Doses in amount higher than, as we mentioned, 10 times the recommended daily allowance. It has been interesting enough that, or written enough, that some toxic effect of vitamin A has been observed in infants fed large amount of chicken liver daily for 1 month or longer. Each serving contains this is the amount of a serving, I searched for it, 36,000 international unit, which is more than 20 times the recommended daily allowance for this age group. There is many chronic toxicity. Mention signs for the chronic toxicity: ataxia, alopecia, hyperlipidemia, hepatotoxicity, muscle pain, visual impairment, hypercalcemia, non-specific signs and symptoms. We can diagnose toxicity by the symptoms, as we mentioned: hepatomegaly, hyperostosis, increased cerebrospinal fluid pressure, so cerebri. As for the lab, circulating vitamin A concentration do not constantly reflect vitamin A stores, because most vitamin A, as we mentioned, is stored in the liver, so they are not a reliable mean of detecting vitamin A toxicity. Patient with hypervitaminosis A may have low, normal, or high serum level of retinol, depending on the timing, the quantity, and the form of vitamin A ingested and the patient age. There may be elevation in the liver enzymes, serum calcium, serum retinol ester in the fasting state are sometimes used as a marker for chronic hypervitaminosis. Then let's talk about the cystic fibrosis. Although children with cystic fibrosis are at risk of fat-soluble vitamin deficiency due to pancreatic insufficiency, we mentioned that pancreatic enzyme play a very important role in the metabolism of vitamin A. Standard supplementation regimen may lead to excessive level of vitamin A. Then there may be deficiency or toxicity in cases with cystic fibrosis. This has been found in one study. Children with cystic fibrosis who were given standard supplement, total vitamin intake, and serum retinol were evaluated, raising concern about the possibility of chronic toxicity, which may contribute to the cystic fibrosis associated liver and bone disease. Vitamin A toxicity may result in hepatotoxicity, leading to cirrhosis, vaso-occlusive disease, histologic. For sure, we will find the hepatic stellate cell, proliferation of hepatic stellate cell. Factor increasing this toxicity might be the underlying liver and kidney disease, the use of some of the drugs, like as example, the tetracycline or the alcoholism. Finally, my take-home message: vitamin A from animal sources or supplement is threefold. It's more likely to cause toxicity than vitamin A from plant resource. Vitamin A is crucial to cell differentiation and integrity in the eye, and deficiency causes xerophthalmia. Vitamin A also has an important role in the phototransduction, and deficiency might cause night blindness. Vitamin A deficiency is also associated with bone growth, non-specific dermatological.
خلاص.
أنا خلاص أنا قربت. And impair immune function. Effective replacement approach has been defined for at-risk population. The diagnosis of vitamin A deficiency is usually made by clinical finding, can be supported by measurement of serum retinol level or the ratio of retinol to retinol binding protein. In population where dietary intake of vitamin A is adequate, there is no evidence that supplementation of vitamin A is helpful for preventing cardiovascular disease. Maybe this point will remind us with the high doses given to of vitamin D and vitamin C in facing the COVID era. Again, supplementation may even have harmful effect on cardiovascular mortality, cancer, and bone death. Therefore, if dietary intake of vitamin A is generally adequate, we recommend not supplementing vitamin A for disease prevention. Acute toxicity can occur in adults. Chronic toxicity occur when longer-term ingestion of vitamin A doses is higher than 10 times the recommended dietary allowance. Preformed vitamin A can have teratogenic effect during the first trimester of pregnancy at a doses of only several times recommended daily allowance. Circulating vitamin A concentration do not constantly reflect vitamin A stores because most vitamin A is stored in the liver. Measurement of serum retinyl ester may be helpful. And thank you.
Thank you so much, Dr. Ragad. We have one question here. Is breast milk fed need vitamin A supplementation?
المفروض احنا كنا كاتبين ان بوست بارتم does not need vitamin A وهي المسج الأساسية لو المother دي أو lactating mother taking food adequate in vitamin A we don't need to supplement.
Okay.
Well, it must be only given for deficiency, whatever the cause, whether it is nutritional or underlying cause. It's very important not to give too much vitamin A. We are afraid that the coming era we will face vitamin A toxicity.
Yes. Okay, thank you so much, and inshallah we will continue tomorrow. This is the end of our sessions today. I thank all attendees. We have still till now about 245 attendees, and this is good. So I thank you so much, Dr. Ragad, and all, and wish to see you tomorrow, Dr. Mazhar. Thank you for your attendance with us.
Thank you. Thank you. Good night. Good night.
Okay. Assalamu alaikum.
Alaikum salam.